morning, friends. It's so nice to see you all sitting here. Smile faces. Right? All excited for today? We are also excited, little worried also because this is the second time we're doing it. We don't have much experience in conducting this symposium. Okay? We're also learning how to conduct. Okay, so we are running short of time because 29 of you are going to present cases. That means you give 10 minutes to the person, it's almost quite a lot of time going to consume. I want to finish it by lunchtime, so I want to keep my talk brief. Okay? Now, end of this 1 year, I hope we kindle in you a thirst to knowledge. Right? From now onward, I don't think you've stopped learning at all. I'm sure about that. Clear? So please, when you learn, always, I may tell you something, Ramesh will tell something, some other teacher will teach something. Always ask why before you accept it. Never accept anything without that why in you. That why should be the life's goal, okay? Anything, everything in life, ask a why before it. Imagine simple. You take an impression, I tell you, apply tray adhesive on the tray. Don't do it blindly. First ask, what is the tray adhesive? Then ask me, why should it be applied? Only when you get the answer for it, you should do it. Otherwise, it becomes mere mechanical things, right? A robot doing treatment. Understand? If you can tell the robot, paint tray adhesive, it will do it beautifully, much better than you. You should know why you do anything. Otherwise, knowledge is not perfect. You will tend to believe steps sometimes, do wrong steps without even knowing. Because the reason for that step, you don't understand. Then how do you know the steps you did? So many steps you have, right? Treatment planning, for example. We tell you, put an articulator, close it gently, open, close, open, close. You write down a list of things, right? How to proceed. Remove the posterior segment. Then plan vertical. Then put the posterior. Get all the dots. Everyone has the list of it, right? You follow the list alone, not thinking for one moment why each step was done. You have learned anything. If something changes, the technique changes, you'll be lost. If you know the principles behind it, what made you do those steps, then you'll understand. If the steps change, you need to adapt to that because you know why you're doing it. Understand? Today your impression, tomorrow digital impression, right? Or not tomorrow, today digital impression. Correct? Why the impression, what you do with it, is the base. The technique changes. The restoration, composite, everything changes over time. But you must understand, for example in composite, one thing you must understand. Clear? What material you use, what filling material comes in, what the strength the material has, they're different. They change over time. The composite I used was so weak. Today it's almost a permanent filling. Correct? So techniques change, material change, but concepts are always the same. So understand the concept of everything before proceeding. Clear? That's number one. Otherwise your learning won't be effective. You won't enjoy it. Now I understand most of you love dentistry, right? Have that feeling come into you? You start liking because you understand everything. When you sit before the articulator and do the planning, what do? You're planning everything, right? You think. It's like puzzle solving. Enjoyable to do. That should come into your mind straight away. Clear? Second thing, please, patients sit on the chair, they trust you. Clear? They trust you. They give the body to you, right? Please don't break their trust. They won't know whether the thing you put in their mouth is proper one. They don't know the margin you gave is not really good on the crown. They won't know that. You must still go and say, oh, it's a good doctor, you should put a nice crown. They won't know you compromise on the infection control. Will they know it? They won't. You can easily cheat them, correct? But one thing on that also, when you cheat, you think nobody saw it. Your assistants see it, your staff see it, your close associates know, so they know you're a bad person. Correct? So don't expect that trust, that love from them if you're a bad person in your heart. For the patients, they don't even know that you did it bad. They may go and tell outside you did a good job, whereas you have done not so good job. Clear? So, integrity. What you believe is true must be true for every time. No compromise. For example, I won't hurt my child. Should anybody tell me that? It is something dictum inside me, right? I can't say, oh, you pay 10,000 rupees, I'll give one slap. That's not the way we do, right? So every time you treat a patient, think that way. What you know is right can't be compromised. Not even a wee bit. Clear? If you do that, I promise you, you'll have a satisfying life. After 20 years, you look back, or 30 years, look back, how you lived your life, you'll be happy about it. Clear? So with this, we'll start today's symposium. Clear?
Good morning. So good to have you all. So we are not here. Can you all clap your hands? Audience, everybody is okay. Great. So welcome to this ODD Symposium on behalf of Dr. Vasan Dental Academy. We are so proud to have everyone here. This is something like, it's like a family. You don't have to be in tension. You don't have to feel, just we are like a family, right? You are just sharing your journey with us. All we wanted to know is, we are not looking for great presentations or great orators here. We just want you to share your real challenges, your journey for this 1 year, how you did all this stuff. So be very genuine, be authentic, be yourself. As simple as that. Okay, you don't have to get tensed at all, right? Nobody is going to judge you here. Nobody is going to give you great things here. Okay, so with this background, strict rule number 1, time you have to keep up. Because yesterday night one presentation was added because of another enthusiastic ODD doctor. So that means we have around 27 or 28 presentations. That's a huge number to complete in 2 o'clock. That's why I have I have messaged you as it may land up to 2:30. But if you can do it in 10 minutes, definitely we can complete it by 2 o'clock. Because we wanted to give you at least 1.5 to 2 hours time for you to get ready for the graduation. Evening, no problem, no tension, nothing. Just celebration, just enjoy. Okay? So, ready? So, with this, I want to introduce our proud ODD alumni. He got graduated last year. He has traveled all the way from Kerala just to see you people. Do you know why he came today? Last time he came here, but he had a commitment that he has to leave the area by 7:45. You are so feeling FOMO will be there, no? What these people did after they left. Today you wanted to see what is happening in the graduation, the entire ceremony. So he has blocked the entire day. He wanted to stay here. Next day, Tuesday morning only, he is going. Because suddenly his course date was changed last time. So he was in a hurry. So with this short introduce, he is Dr. Blesson George. He is one of the finest clinician I have seen. You have to just follow him in Facebook. He has some excellent hands. Okay, so he is going to share his ODD journey with an ODD alumni presentation. We are going to start the symposium. Can you all clap? Yeah, thank you. You want this mic or anyone?
From the next presentation, we'll have the countdown. 10 minutes countdown will be on the screen. Okay, sure. Okay, we can start. Here, I'm not going to present a case in a detailed way, just presenting what was my life after I came into this institute and becoming an occlusion-driven dentist. Okay. And by the grace of God, I reached here. I have good mentors, good friends all around from India. I thank God for that. Just a glimpses of what I have stopped in the last symposium. This was the last presentation or the last slide of my graduation symposium. It is not who you are that defines you. It is what you do. It is that defines you. Because you may be a general dentist, you may be a specialist, you may be X or Y, but if you're doing a good dentistry, it is that defines you. And I'm so proud that I'm a stomatognatic specialist. Okay, just glimpses of my life. This was me in 2015 with 130 kilos. And this was me in 2020 with 81 kilos. Okay, then in 2025, here I'm with 93 kilos, and this is the photo of the presentation. So why did I show you these pictures? Just because from 2015 to 2020, I unlearned so many things. Nah. I learned so many things from my physically, mentally, and everything was unlearned. And from 2020 to 2025, I relearned so many things. And this institute gave me a platform for that. And I thank all the mentors and everyone for that space that you have given me. Okay, what is occlusion? You have learned about, you heard about everything. And Ramesh sir always say, your eyes cannot see what your brain doesn't know. Okay, that has motivated me to learn and know more about the occlusions. This is what I have in my mind when I graduated from Trivandrum Dental College way back in 2015. Class 1, Class 2, Class 3. Now, beyond this, I was not able to see, and this institute made me see beyond everything. And what has influenced me from this institute and joining this course is that I could give a proper diagnosis of a case. Earlier, when I see some nutrition, then you'll see she's aged or he's aged. That is a reason for an occlusal wear or something like that. But that idea and that perspective has changed a lot. Now, earlier when I see these cases, I will call to the lab and say, your work is not good. What work are you doing? Your ceramics chipping off. Now I will not say. And I will look into the case. If there's an occlusal indicator, now I know these occlusal problems. And second thing, success of my composite case. I'm a biomimetic restorative dentist. I do most of the cases in BRD protocols. And the protocol I follow is 6 lessons approach from Dr. David Ellerman. And one of the lesson is verticalization of force. When you read that thing, you can correlate it with the occlusion. You had to verticalize every force after doing the composite cases. Okay, you have to, when I learned that thing, I got, I was in a high because I learned the occlusion properly. So you know what led to that? I could save these teeth. Normally this teeth goes for extraction, but I could save this. This is at 1.5 teeth. I could save this, and I have a follow-up of almost 2 years. And my composite cases become predictive, and the prognosis was very, very, very good. And it was just because I could do a proper occlusion. And I have patients, referring patients, because this is a patient who came to me. She went to so many clinicians. Her primary complaint was a foot lodgement. It's good you do that, takes your name beyond bounds. That was my patients always refer to me their colleagues or their friends, their relatives, everyone. And this was the occlusal. You know, this matters. I'm not going to explain this. And this was the reason I could do a good dentistry for her. And the third thing, your name echoes in your colleague's mind when they face issues. I have seen, and this is a smile designing case. She has done composite many times. It's failing. And she called me, and I could complete. And other situation was implant screw loosening. At 12:30 in the night, I had a call from a colleague that I had to come the morning to, he has charged almost 30,000 for the implant crown itself. And it fractured. So you know that how in a pathetic situation he was in. So I could, because since I know the occlusion well, I could help him out. It is a proper interferences that led to the implant screw loosening. This is the case I completed. There was interferences. So whenever the composite was done, it starts flaring up the anteriors because there was posterior interferences in protrusive cadence. I corrected it, everything, and did a veneer. This is a 58-year-old lady. And the success of my implant case was very, very, very good because I could achieve static and dynamic contacts and implant protected occlusion in all of my implant cases. The simple case, there are so many issues, but still in the protrusive and latrusive cadence, I could get no contact and I was able to give a proper implant protected occlusion for this case. And there are so much referring cases. Now I have patients coming far from almost 150 kilometers to my clinic. It was they were referred by other doctors for TMJ cases, muscular pain, migraine cases. I could treat so much. This is a boy. I think he's 23 years old. He was referred. So there were so much issues. Just a video I was showing. And I had many opportunities to share my knowledge to my colleagues. This IDA, Kottayam, Central Kerala Kottayam, I have, you see the signs, exactly what Ramesh and was in service. The same. I was happy they captured the photo, the same pose that I learned from my mentors. And the biggest thing I get, and I'm getting, is my job satisfaction. I could do a good and a very well and neat work for my patients, and that satisfied me a lot. I got good recognition, I got job security, I got respect from everyone. Usually when I go to a programs or something, they call me prosthodontist. I will say no, I'm not a prosthodontist. I'm just a dental dentist who love occlusion and who learned occlusion very well. Why you came here? My prime motive was professional ethics, because I don't want my patients to have 28 crowns up and down for all of my occlusion cases, just because I will not say I'm 100% ethics, but I am trying to reach to be a good ethical person. So this has made me come here and do the course, do the work, and proceed. And my big dream is about to come. I'm going to launch my new clinic in Kottayam itself. It will be launching in another 2-3 months. It will be launching. And we have just an architectural design for the same thing. Because I cannot work in my present clinic. There's a space constriction, there's everything. And my dream has become big so that I am beyond my present clinic. So I have to set up a new clinic. Might be in future I have to move from here. But now our dream has reached here. And I think there's 3 minutes now. I will complete quickly. This is a simple case. The patient came to me, I think 1.5 years back. She's 52-year-old female. She's working as a senior manager in a federal bank. And her primary complaint was pain on her lower jaw bilaterally. She doesn't have lower posteriors because upper posteriors were supraorbital touching the lower gingiva, and she's having issues with that too. So tenderness of masseter muscles, there were signs of occlusal disease. So primary complaint was managed. I gave her a lower overlay type deprogrammer. I have presented this during my exercise, and sir told me don't give a lower overlay type deprogrammer, but I have no other way, because this crown was coming off. Now if I gave her the deprogrammer, by the time she removes that crown will come out. It was a situation. So I was forced to give her deprogrammer on the lower arch, but the pain has completely subsided in 2 months. These are the intraoral photos. You can see the occlusal wear and everything. These are the dynamic movements, and there was so much interferences. You can see the non-key cervical lesions. And my occlusion eyes is open now. Okay, this case has traveled me for almost 1.5 years. I have convinced her for ODBA test. I did ODBA test, Dawson's by manipulation. The lot test was negative. And with the previous line on this side, there's a huge gap of 1 year, because we were doing implants for her from the upper and lower jaws. She wants only implants because she's working in a good profession. She doesn't want removable appliances. So we opted for a implant system. So when she came back, I did a arbitrary jaw relation, because I want to have a metal framework to take a good CR relation. Then after that, jaw relation, vertical jaw relation. No, you can see the framework, posterior framework. With that, I made a centric relation. I just mounted, and functional wax up was done on the anteriors itself. Posteriors, both sides, upper and lower. It was implant prosthesis. Composite anterior, lower anterior composite was built. I asked the lab to do for the premolar also because I want to change the premolar. There was crown on one side and there was, I have to reduce the height of the other side premolar because it was supra-erupted. And this was the case. It came from the lab as this. And the goals of an audio editing is dots at the back and lines in front. And the most troublesome procedure I ever had in my life is this thing. Everything was easy, but this thing, no. And for this case, it was much more pathetic for me. And I will say why. Equilibration plate, no. I was doing equilibration. As soon as the patient knows that her functional functional occlusion was very good, she could chew on the table. No, I was walking on the table. She stopped me. Doctor, I need one thing. I told, what? No, I need to change all my anteriors. This happened last week. Everything was said. We told her, we discussed, everything was done. So I was telling that when the posterior, she was not having posteriors. When she knew and her system came to know that there was a good functional occlusion in the posteriors, suddenly she want the anteriors. Till that time, she doesn't want that anything. No, I don't want this. You'll see her anteriors. This was. So what I did, I just stopped. I sent her home. You go, ma'am. We'll have a discussion after 1 week. I have a symposium to come up. I was ready to present her cases in a total everything. And this situation happened. And by that evening, her daughter called me. She's also my patient. She told the doctor, I have seen my mom so happy after almost 10 years. So I told her, what? Why? No, she was able to chew well. She as soon as reached home, she was eating, and till night, she was eating everything she could get. I told her, no chicken legs, like that, no chips. Except that she was, so her daughter called me and that she's very happy and now she has got a chubby cheeks. Because no posteriors now. So they were all happy, I'm happy. So I told that, okay, we'll go with anteriors. After some time, I need a break. So by next week, I'll be starting. This is the surgical protocol that I have completed. My wife is a maxillofacial surgeon, so together we completed the case. Next treatment plan, smile designing for the upper and lower. To achieve the anterior coupling. I have achieved the anterior coupling with the composites, but she wants it to be with the veneers. So we'll be going to do that in a couple of weeks, changing crowns and everything, and finally equilibration we'll be doing. Okay. And for the protection, long-term overlay type deprogrammal as neck guard I will be giving, and follow up every 4 months to check the occlusional status and equilibrate if needed. And this is the cord I'm giving you. You all have reached a point. Now you have struggled, you have dedicated, you have done your hard work, and you reached this day to be a graduate from the as an occlusion-driven dentist. So this is not the end, guys. This is not even the beginning of the end, but perhaps this is the end of the beginning. You have reached, and your beginning has an end. That's happening today, and your journey is going to continue from tomorrow. Thank you. Thanks a lot.
Thank you, Blesson, for this wonderful presentation. Can you all give you a good round of applause for him, right? Okay. So, he's just messaging me on 14th July 2025, exercise 45 to 72, 134 to 137, 147, 148, 150, 155 to 161, 167 to 165, 166 to 175. That means, so almost many of the exercises not completed, and the 19th and 20th July is going to be the graduation. Okay? From there to here, I have seen his journey. Can you all understand? So what I'm trying to say, he just blocked, he closed his clinic, he finished everything, and a final presentation is submitted on the day before. 1:23 is the time he has finalized here. Sitting with me here, that's the morning. Early morning, I was sitting with him, and we finalized the presentation. So from there to here, it's a huge thing. Thank you, Blesson, for this wonderful presentation. So we would love you to come and do the same next year. Okay. So with this, I'm going to introduce one of the finest person. By this time, everybody knows whom I'm going to introduce, right? Okay. Can somebody guess? Okay. Nobody is afraid of Dr. Vasant sir or Dr. Ramesh sir here today. Frankly speaking, sir, they are all clapping so that you understand, no? But Vidading sir, you have all the rights. You can ask whatever you want. And I'm getting a message on 21st June 20, sir. The phenomenal thing about sir is 30 cases of ODD, 24 FMRs, 2 stabilization splint, 4 ortho cases, some completed, some are undergoing, DASA around 30 cases. What more can a mentor expect from a student like him? So, I was almost in tears when I saw this because this is a dream. Okay, with this small, it's a big introduction, right? You all know the numbers. Okay, fine. So before this, I had Dr. Kuntal Soni, sir. He gave one information, 45 deprogrammers delivered is the highest number I have seen in the entire batch, and he has overthrown. I don't know who is going to beat his numbers. I don't even know. Okay, with this good round of applause, I am going to invite Dr. Lakshmanan, sir, from batch 4 to present the case in the symposium. Please, sir.
Good morning. Yeah, we're ready to go now. Okay. I'm Dr. Lakshmanan. I'm a maxillofacial surgeon. Don't be surprised because I'm into restorative dentistry nowadays. I have given up maxillofacial surgery because it was not good for my health, so I've given it up. Now I am a proud restorative dentist like many of you here, and my health has improved a lot. My finances have improved a lot. I have grown into leaps and bounds after taking restorative dentistry. And so, my aim to learn occlusion started in the year 2009. You know with whom? Dr. Vasant. So, I started my occlusion journey in the year 2009 with Dr. Vasant at Vijay Dental Cadet Academy. At which, yeah, I was there. He's surprised. Okay, so I saw him talking there about occlusion. Okay, it was all Greek and Latin. I didn't understand a bit of it. Then the academy people served biryani in the afternoon, had a stomach full of biryani, went home. Okay, and then I started learning maxillofacial surgery that time only, post-graduation. I finished my post-graduation, went into the clinics, started a small clinic somewhere in Chennai. I was not successful. God pushed me to my native place, Hosur. It is very close to Bangalore, 30 kilometers from Bangalore. It's called Little England. So Little Ooty. Fine. Then I somehow wanted to learn occlusion. It was there in my blood. So I didn't know where to go. That time it was Dr. Stuart Orton Jones who had come to Dent Care to teach about occlusion. I went there, and you know whom I met there? Dr. Vasant again. That is when I took occlusion very seriously. A man of his age, he still wants to learn something which is the footsteps of dentistry. Occlusion is the basics. He wanted to learn occlusion at that age. He had come there, we learned, and I never understood anything. I went back to my place after paying 10,000 rupees for that. And I didn't learn anything at all. So I went back. And again, after 3 years, the same Stuart Orton Jones had come to Mumbai. I went there, and I sat with him for 2 days to learn occlusion. Not a bit I took from him. Because it was 2 days, and you cannot grab anything from that. Then I lost hopes about occlusion, came back to the clinic. I had a little bit of busy practice by then. People used to come with broken fillings, chipped off crowns, TMJ pain, neck pain, shoulder pain, all stuffs. I knew something is wrong with occlusion, but what is wrong? I couldn't identify. It is the biggest shame sitting in the clinic in front of a patient who trusts that you can help him out and you are not able to do that, being a great professional in that subject. It hit me very hard. I was just looking out from where I can learn occlusion. Just then, I saw in the Facebook about this brilliant takeoff by 2 great humble souls who can give their life to help people around. One is Dr. Vasant, the other is Dr. Ramesh. So I joined that course immediately. You know why? Because Dr. Vasant was there. I wanted to learn from him. I had been to his clinic along with my friend, my roommate, who used to work for Dr. Vasant. And that he said, Dr. Vasant will never allow you to touch a patient in his clinic unless he has confidence in you. So that day, I decided I will learn occlusion from Dr. Vasant. And this platform has helped me a lot to be bold, brave, to present a proper oriented treatment plan to any patient who walks into your clinic. There are no ifs and buts. It is just plain business. You talk to the patient, you are bold, effective, and present the treatment plan according to the platform set by ODD. And it makes a lot of difference. I can bet not a single dentist in your area can present this diagnostics and treatment plan. Unless and until you are an ODD specialized dentist from Dr. Vasant Dental Academy. Now with this brief introduction, I will go on to present a small case, very briefly, about how I executed a treatment plan for a patient who had no tooth pain, no joint pain, only muscle pain. And this domain, muscle pain, is not related to dentistry at all. That is what the other people think. The physicians around you, the people around you, the patients who trust you more, they think that muscle pain has nothing got to do with dentistry. Now, this young lady, not young lady actually, this lady, occlusion-driven dentistry, a case of TMD treated by equilibration and restorations. Okay? So Mrs. Lima Rose, age around 47 years, present to my clinic with pain in the lower front tooth. The diagnosis was non-vital teeth in relation to 3-1. Cold test is positive, there is no pain. IOPR shows periapical radiolucency. The causative factor for non-vitality is attrition of the lower front tooth. So this is, anybody can do, go for a root canal treatment. I advised root canal treatment. Her husband got treated by me for lower edentulous arch, full mouth implants given. Very happy patient, very nice person. You can call him any number of times for appointments, he'll come. And any kind of thing that you tell, he'll happily accept. Okay. So he had a lot of belief in me, thinking that I will do something good for his wife. He brought up, so root canal initiated, root canal completed. After that root canal completion treatment, I wanted to examine the other parts of the mouth. So we found that this spacing in the upper and lower front tooth segment, there was a severe deep bite, class 2 caries in relation to 2-6, wear pattern noticed in the lower canine teeth, peg ladder in relation to 1-2, occlusal scheme, occlusal group guidance with functional and non-functional interference on both the sides. Okay? Protrusive interference present, canted occlusal plane, and neck and shoulder muscle pain present. She is under treatment for that with a physician. Okay? So now, when you find all these things, it kicks. Do something for the patient. At least tell them there is something wrong in your stomatographic system. And they were amazed to see a dentist talking about muscle pain. So they were about to leave the clinic after the root canal treatment was finished. And then I told them, everything is fine. You will not have any pain. You can leave. They were seated in the sofa. Just then I turned and I said, this thing, the lower occlusal pattern, the wear pattern which I see in your mouth, is largely related to TMJ. And your wife may have tooth pain, muscle pain, or neck pain. By the time I told neck pain, they sat again on the sofa and they wanted to know why neck pain, because of tooth. And then I started explaining to them. Deep bite on one side, peg lateral on the 1-2, spacing present, and a severe occlusal wear out pattern on the lower incisors. And so this pattern of the face shows it's a square shape with the very active masseter muscles, deep bite present. And then I started examining her. TMJ, all kind of muscle pains were present. Severe pain on the sternocleidomastoid muscles and the neck portions, including the splenius capitis, medius and anterior, posterior, everything. Okay. So then, after this presentation, they were very much excited to learn why this kind of pattern is happening to me. Then after this, X-rays were made. The TMJ were fine. Not much of changes in the bilateral TM joints. Root canal completed. And then the medical history of the patient. The medical history, the physician who is treating her has very clearly examined her for vitamin B12 deficiency and vitamin D deficiency. Almost okay, not very much changes in them. And then They have been treating her for migraine, for dizziness and neck pains. They have examined and they have come to a conclusion that is purely neurological, and they have started treating her on painkillers, muscle relaxants, along with some psychiatric medicines. Anything in medicine we are not aware, we push it to the psychiatry. There is no other go. Then we gave her a very strong presentation telling her that I can solve your pain, I can do something for you, come to us. So the beginning point is DASA. This is a wonderful appliance which can show that you are true to the statement what you have given. So DASA worked for her very effectively. 1 or 2 weeks only she wore the DASA, over a type of DASA, very effective, and they wanted to start off with ODD. So usually people who present a treatment plan, they just start off with the case. But here in ODD, we have a plan. It's called occlusion-driven bite analysis test. She was taken aback. Why so many tests for teeth? Then we started off with the intraoral presentation. We shown her also what all the changes happening inside her mouth. So light body impressions were made, face bow transfer done, centric registration, single point contacts. Then the models were presented to the lab for sectioning, articulation done, and we were okay with the single point registration. Whatever was present in the mouth, the same was there in the model. So we are sure that our articulation pattern is correct. And then we started off. After CR bite registration, you can see the amount of mandible has gone back. So that much of separation was there between our anteriors. Only the posteriors were in contact. So this itself showed her that we are in a right path. So after this, we presented her the treatment plan. So single point contract registration in 2-7, mesopalatal, mesial cuspal incline, and the 3-7 means the same buccal incline of the buccal cusp. So we were satisfied with the model analysis and the procedures so far. And then we started off with equilibration chart sheet. The vertical at CR was 0 mm, and then vertical at maximum intercuspating position is minus 2.5. That is, there is a slide of 2.5 mm from CR to ICP. Then verticals without posterior segment is minus 3. That means it is slipping another 0.5 mm. So the point here is at centric it is 0. At ICP, patient's vertical, it is minus 2.5. When you remove the posterior segments, it is another 0.5 added. So it shows there is a large slide between CR and ICP, but between ICP and the posterior segment off is only 0.5. So I decided if I can eliminate the posterior interferences, I can reach my ICP. So my pattern of thought here was, if I can equilibrate the posteriors and I can eliminate the interference in the posterior segment, I can reach my ICP, which is the vertical. And that vertical at CR, there was a separation present between the anteriors. So I decided I can do equilibration in the posteriors and restoration in the anteriors so that I can set my vertical. Then I started doing my equilibration. So our equilibration started with at 0 and then slowly proceeded to reach vertical at minus 1. At minus 1, I was able to equilibrate all my posteriors, achieve contraction all the posteriors with the open bite in the anteriors. The lower incisors very clearly showed a wear pattern with an occlusal cant. So I decided I can restore both upper and lower. Then I told the patient what can be done for you to achieve this is your mind mapping. So in this mind mapping, I decided to equilibrate all the posteriors so as to reach at a vertical of minus 1. At minus 1, all my posteriors were in contact with the open bite in the anteriors. So it was more or less like a class 2 position where I had very good overjet and overbite. If I can restore both the upper and lower anteriors with veneers, I can finish my job. She also wanted a space closure between the upper anteriors and the lower, nice aesthetic alignment of the lower anteriors. So we proceeded with veneers for the upper and lower anteriors, equilibration in the posteriors. So my lab instruction was like normal condylar position, no condylar TMJ pain. Wax up upper and lowers at a vertical of minus 1. Lower incisor edge to be flat with no sharp incisors edges. And then centric stops, anterior guidance, cusp of speech, all that was instructions were given to the lab technician. A nice beautiful wax-up was presented in the both upper and lower anteriors, temporaries made, and then patient, we started with equilibration. After you receive your temporaries from the lab, we have to start with equilibration first. So I started equilibrating the posterior teeth with a coes deprogrammer. After the posteriors were equilibrated, then the vertical will be -1. After the posteriors were equilibrated, I put on my temporaries of the both upper and lower. After that, you still have to put your coes deprogrammer and equilibrate again. After the equilibration, we switched on to the temporaries. With this temporary, equilibration was done and occlusion was achieved, dots in the front, dots all over and lines in the front. Then preparations were made. Digital scans were made for this patient for both upper and lower anteriors following the PAP rule. This is with the PMMA, temporaries given to the patient, upper and lower, equilibration done with the temporaries, dots and lines achieved all over. Anteriors, we have good guidance. Posteriors, we have good dots. So patient was happy with this. Usually, these kind of patients are very happy with DASA and PMMAs. They have no complaints at all. But for some unknown reason, after we switch from the PMMA to the originals, they start having pain again. And here, you are in a fix. You don't know what to tell them. The only answer is DASA again. Because not all kind of muscle pains can be eliminated with your restoration alone. There are some other factors like stress and other things which happens in and around them. She's a teacher, by the way. She keeps writing all the day with her the right hand. And this pain is purely only on the right side. With the sternocleidomastoids, with the trapezius, with the occipitus muscles, all that area she is getting pain. But by the time she puts on her DASA, everything is relieved within half an hour. At least we are able to push the patient to a level where medicines are off, where psychiatry is off. She's just with the DASA appliance. So PMMA temporaries were working very fine. I put her on DASA with the PMMA temporaries, very happy. Then we switched on to the permanents. Anterior veneers bonded, lowers also bonded, occlusion checked, all lines and dots achieved, patient happy. Group occlusion, occlusion was also achieved, all interferences eliminated, canine guidance achieved on both the sides, patient is happy. DASA given, patient is comfortable without any painkillers, husband also happy, but then she comes back to me after a month or so telling the pain has come back again. So the conclusion in this presentation is that the occlusal adjustment can be very minimally executed with just purely based on composite restorations or some equilibrations or along with equilibration and restorations. But then the standing point should be there. The occlusal alone may not be contributive to neck muscle pains. There can be other factors also, and your DASA remains your sole savior. With all this done, she experiences pain around the neck and shoulder, but it is relieved after DASA wear. Though this is annoying, the DASA is considered therapeutic here, though we began using it as a diagnostic appliance. Occlusion has an overall effect on the body structures. Many people go around physicians seeking help for muscular pain in and around the neck region. The issue is often considered psychological or idiopathic. It is high time the ODD is recognized as a treatment modality. Now with this, I have again taken upper and lower impressions, Facebook transfers, CR records, and then I wanted to stabilize the joint. I still have a doubt whether the joint is stabilized or not. So I am putting her on stabilization sprint next week. Hope this presentation has given you a brief idea about how a case can be executed with ODD principles. Thank you.
Thank you, sir. Thank you for this wonderful presentation. So I'll take this as a first 5 minutes as a testimonial and followed by the next 10 minutes as the presentation. Okay. So what was expected from sir in the evening has been delivered now itself. Okay. So happy. Yeah. Sorry. So one doubt for me, sir. Can I ask? Everybody will be happy, no? Why stabilization splint after all this? That's a genuine doubt I had.
I'm not sure because the patient is coming to me with muscle pain again. I'm not sure whether I have taken my TMJ and the disc, the condyle and the disc into the superiormost position. The patient, after a month or so of with the permanent restoration, she comes to the clinic. We do Dawson's bimanual palpation, and I see the anterior is not in contact again. That means the lower jaw is still trying to move backwards. And what I learned from this presentation is that it is always better to keep the patient under temporaries for a very long period of time, so that you can have a checkpoint on the TMJ because there is no single radiological diagnostic tool to tell that the condylar assembly has gone into its CR position. We cannot do that. The only thing is that patients feedback whether they are happy without any pain, and we trying to achieve the CR position with bimanual palpation with all contact points in the mouth. So that is pushing me to the stabilization splint again. So I want to give her a stabilization splint and then see if her pain goes away with that, achieving all dots and lines on the stabilization splint, and then maybe I will change the restorations again. I don't know. I'll have to
Give a
check.
suggestion, Dr. Lakshman.
Yes, sir.
See, the problem is not joint not stabilized. The problem is maybe the occlusion you gave is not in total CR.
Excellent, sir. Excellent.
That's
Excellent.
the reason.
Excellent. Excellent.
Not about stabilization.
Correct, sir.
The joint is okay. When you started the treatment, joint is okay.
Okay.
It can go home, meaning it can go to centriculation.
Okay.
But what happened was during the recording and during execution,
Correct.
some slippage happened, and the occlusion now in not CR.
Not CR. Okay.
So I'll rather suggest you, now you have the impressions, models taken again, recorded in centriculation, mounted, equilibrate.
Okay.
Then you'll know how much far you are away.
Correct.
You might still be able to achieve the CR with fresh equilibration.
Okay.
Then all you need to do is go back to the patient mouth, do the equilibration.
Correct.
But if you find you're too much away, maybe you need to alter the anterior restorations.
Correct.
Then again you have an idea of how to do it.
Correct.
That will be the way to go and not giving a stabilization splint.
Correct. Actually, in this case, whatever you told, I've already executed. The lower anteriors, when I did this without doing CR mounting, I did a bimanual Dawson palpation and I was able to see the mandible going way back. So what I did was, I did composite restoration on the veneers. And then I brought the lower anteriors in contact with the upper. And I gave her a new DASA. But then she still comes back with pain. So my thought process was, rather than building up the lower anteriors again and again with the composites on top of veneers, I thought I'll go in for a stabilization splint. But sir, I think this is a take-home point for me. I'll get back to the basics and then work it out.
Yes.
Yeah. Thank you.
Thank you, sir. Thank you. It's a very crucial point which I wanted to bring in here. Everybody will be happy. If there is somebody, we have to make the giants clash, no? So, and we enjoy. Thank you, sir. Thank you for this presentation. So, next presentation. So, we don't have much time. So, it's going to be next time. It's going to be a timer there. So, you can look into the timing. So, it makes your life easy. Actually, otherwise, it's very difficult. Okay. So, next presentation comes from Dr. Meena Shah. February, I'm just messaging her. Is there any help you needed for ODD graduation and symposium? Plain answer is, I am on it, sir. I am there. So, I'll do it. Okay, February, I got into depression because of ODD. Can you all guess why? Okay, can you all guess why? If there are some 4 or 5 people who brought me out of depression, one of the person is Dr. Meena Shah. Only 5 people were ready by February to get graduated. From there it started till yesterday night. It was going on and on. So, thank you for bringing me out of ODD depression at February. You're one of the finest person. Okay, with this introduction, you can start your presentation.
Thank you, sir. Very good morning to all, respected mentors and my dear colleagues. Before I start my presentation, I would like first and foremost to thank God Almighty for His blessings, grace and guidance throughout this ODD journey. I would like to express my heartfelt gratitude to my mentors, teachers and guide, Dr. Vasant sir, Dr. Ramesh sir, Dr. Malar ma'am and Dr. Vijaya ma'am for their invaluable teachings, encouragement and constant support. Ma'am, that is also very important. Sorry, ma'am. Which have been instrumental in shaping my learnings and clinical understandings. I also sincerely thank my colleagues, family, and well-wishers for their support and encouragement throughout their ODD journey. Friends, with this, I would like to present my case in ODD way, but please excuse me because my documentation is not up to the mark. I've tried my best. but I've missed some steps. This is my case of equilibration and restorative case. The patient had a complaint of left, she had come to me for left TM joint pain and a clicking sound from the same side. She also had a history of fracture premolar, which was replaced with implant. So I asked her the history about that. And she was also not comfortable in chewing from the same side. And she was complaining of lower jaw, which has, whenever she speaks, the jaw shifts on the right side. So this was the complaint. She had come to me. So on comprehensive examination, I find out the TN joint, I could appreciate the clicking on the left side, and muscles, masseter and temporalis were tender on palpation, and examination of teeth, adhesion was present in lower anteriors and upper anteriors. But the posteriors were good, well intact, the anatomy was good. Surrounding structures were also clinically intact. So after examination, I gave her plans, Koya's deprogrammer. So she wore it for 6 months, more than 6 months, and her symptoms were resolved. So we decided to go for ODBA test. I explained her about the bite derangement, and she was ready for the ODBA test. And these were the pictures: front profile, closed mouth and open mouth, side profiles, the intraoral photographs. You can see MIP, open mouth. You can easily appreciate the lower anteriors and upper anteriors were treated, and there was a space between lower anteriors. Right functional, right non-functional, left functional, left non-functional. Then this was the protrusive. This was the upper arch and lower arch. So I explained her everything, and she was ready for the treatment. So we started with the upper and lower impressions. Then the Facebook record was made, and mounting with the Facebook and CR bite was done. And on the equilibration sheet, we could find that there was, after equilibration, I could find that only anteriors needs to be built up. So I decided to build them up with the composite. So that was the treatment plan, and after equilibration, these were the models. I could achieve good static contacts in all the posterior, and there was a space between anteriors. So the wax up was done in the anterior by, I did the wax up myself in the composites, and during the procedures, you can see I did the build up. Down. Okay. So after the build-up, this was the case. I could achieve good contacts. This was open bite, right functional, left functional, and protrusive guidance. The patient was happy. The static contacts were achieved. You can make out the mentalis. This was before treatment, after treatment, the muscles have relaxed. The mentalis especially. And this was her smile after treatment. So thank you for patiently listening. Thank you so much. I'm not a good orator, so I can't speak more.
Thank you, doctor. Special thanks for completing in. Thank you for this. Okay, how much? Okay. Great, Dr. Meenakshi. She is a phenomenal clinician. To be very frank, if there is one student in that particular batch who has been consistent, for example, if you announce an exercise, that will be completed by that month, which is something nobody or Nobody has done. Okay, you all know that. Can you all give a good round of applause? Okay. If there is one student whom I have not followed regularly for update of finishing an exercise, she is one among them. So I can say 1,000 things about Meenasha. She is a phenomenal clinician. Only thing is she also has an aversion like me to laptop on these presentations. Yesterday when we were discussing, we know who made the presentation. So she knows the case better. If you ask her to speak about the case, she'll speak. If you need to change anything, no sir, let's talk this because this was done by another angel. Okay. So thanking that hidden angel who has done this job. Okay. With this, I'll introduce Dr. Reggie Matthews sir. So proud to have him here because we met in Stewart sir course. So that is where we learned. Having them here as our mentee in the ODD journey is very, very special to us. So with this small introduction, he is also a phenomenal clinician. These people are very, very curious about implementing what we are teaching. That is the best thing about Reggie Matthews sir. Let's see what he has for us. Okay, sir.
Lakshmanan, hope you remember me. Yeah, we are at the same college. Yeah. Okay. Good morning, all. And I would like to thank my mentors, Dr. Vasant, Dr. Ramesh, and Malar ma'am, and also Mrs. Vijay. Okay. Let me be informal little bit because I will introduce myself a bit. Because why I think is to introduce my background is because I never thought I will take dentistry. Why? Because I was born in a family where our primary source of income is from agriculture. So in Tamil we'll say Vyavasayam. But Vyavasayam in Malayalam is different. We are industrialists. So being born in a family of agriculturists, or so-called, so in a glorified way, we can call ourselves as planters or something. But life is tough. So nobody was there to motivate me after my plus 2 to join for any professional course or something. And even I didn't have any idea. So by God's grace or by my luck, my uncle, he took me to a college, our college. Okay, then I thought, okay, if I get a seat, I will do it, no problem, because I never had any ambition of my own. So God took me to this profession, and I thank God that I had this opportunity till now, to this moment, to study dentistry, and I am very much proud. And what I follow in my clinic is whatever I know, I do. Whatever I don't know, I never do. Because I think I need to respect the trust which patient has in me. That's only motivating factor which motivates me to learn. So having said that, my post-graduation also is I didn't do my post-graduation, but I will just share that. In fact, I had joined, I passed out in the year 2000, and I joined in a college in Davangere, but that was the last 2-year batch. But God had a different plan. I didn't get the thing. I paid my fees, but I didn't get admission. I think it's fortunate, or I now believe it is fortunate, because I got to get to know different aspects of dentistry rather than, like Lakshmanan told, stick into one branch. So I am thankful to God. Then coming into ODD, I saw a message in one group saying that Stewart is coming to India and probably this will be his last lecture. I used to see his brochures before, but I never knew what is this occlusion and all, because we never know what is the importance of occlusion when after BDS. So then seeing that message, see that man is so old, when I see his picture, no, he is so much enthusiastic to teach, and they were sharing he has some terminal illness also. So he is taking so much pain. Why shouldn't I? I was motivated to attend his class, and that class changed my perspective with regard to occlusion. And then there I get to know Dr. Ramesh and Dr. Vasant. Then I was talking to my friend Dr. Shija. Anyway, we have to learn from Dr. Vasant. he is equal to Dr. Stewart in India. So we thought about coming to Chennai. Then after finishing our one course in Manipal, I thought I am done with, for time being, I will wait for some time. But again, since Shija was there, we joined just right away. But it was hectic, but now I feel proud that I was able to complete. Okay, that's my small story. So coming to presentation, this is an ODD FMR complete additive case. So I have already introduced myself. I'm Reggie Matthew. I've studied in Vinaya Mission, Salem, completed in 2000. So I express my gratitude. I'm so much grateful for the outstanding mentorship I got from the academy, helping us elevate our standard of patient care. Thank you, Dr. Vasant, Dr. Ramesh, and Dr. Mallat. Truly feeling blessed to be one among your students. See, when the heart is full, words are few. I don't have much words to express my gratitude. Let's begin with the presentation. The chief complaints, the patient reported with pain on 3/4, 3 sits and 1 sits while chewing, sensitivity to hot foods on these teeth, wants to correct abfraction lesions, wants to replace missing tooth, history of frequent headache, wants to correct the arterial anteriors. And his medical history is hypertensive. Then dental records have fractions present, missing 2 sits, 27 migrated to the position of 2 sits, attrition generalized, TMJ hypermobility noted, muscle slight tenderness over the masseter bilaterally noted. Dental and periodontal records 37, 27 and 1 sits, periodontal involvement, but no mobility noted. Consultation, chief complaint, first consultation, chief complaint attended, root canal treatment done, basic muscle examination showed slight tenderness of masseter bilaterally, oral prophylaxis done, implant was planned for replacing missing 3/5. Why? Because the patient wanted to do a minimally, like his financials constraints were there, but we actually planned for a bridge, but 3/6 was not periodontally healthy, so I thought of putting an implant in 3/5 instead. Patient had bridge from 4/4 to 4/8, replacing 4/6, 4/7, supra-erupted 1/6. Patient was delivered an upper arch overlay deprogrammer for muscle tenderness, advised to take ODBA test, advised to change the FPD from 4/4 to 4/8 to correct the curve of P. Implant placed in relation to 3/5. Muscle examination done and explained about the occlusal issues and was advised to wear the deprogrammer initially. After 2 weeks of deprogrammer wear, patient had a great relief in his muscle pain and headache. Patient accepted for comprehensive treatment. Self-evaluation, patient is aware, he is a bank manager, he is educated enough. Patient was made aware of the changes happening to his TMJ and muscles, and was made aware of the importance of preventing further damage to the structures. Patient is motivated and ready for FMR in a minimally invasive way. These are the pre-treatment mounting records. CR bite, first point contact in model compared with patient's mouth, lower model articulation, preoperative intraoral photographs. These are photography records which I took in my scanner. I had a video which it's not working. Extraoral photographs. So chief complaint was addressed. Treatment was done on these teeth. Oral prophylaxis was done. Implant placed to replace missing 3/5. Patient advised to replace 4/4, 4/5, 4/6, 4/7, 4/8 bridge to correct the steep curve of P and get ideal static contacts in CR occlusion. This was my equilibration chart sheet. Mind mapping. Actually, that yellow is direct composite restoration that I didn't mention then. equilibration records, first point contact, mock-up model, +1 was the vertical pin reading at first point contact, -2 was the vertical at ICP. With posterior segment removed also, I got vertical at -2. Since this is an additive case and we have enough space in lower anteriors for prosthetic rehabilitation with patients on video, I decided upon build-up of lower anteriors from 4.3 to 3.3 with direct composites because the monetary aspect was taken care of. Posterior contacts was planned to be achieved with the help of indirect restoration. Lower right bridge was planned for revision. 3.5 implant was planned. 2.7 migrated to the position of 2.6. Root canal treatment was done. Extraction also was done. 2.8. This is the OPG post RCT and implant. You can notice that periodontal health of 3.6 is not that good. So, and that's why I didn't extract 3.8. Maybe later we need to put an implant there. Lab instructions given, articulator, RHCT, H angle, L angle, vertical fits at -2, WhatsApp instructions given, diagnostic WhatsApp from the lab. Now the test drive and documentation in patient's mouth to check whether the WhatsApp is giving ideal contacts in the patient's mouth. Test drive and documentation. Provisionalization phase. I was checking the bite, protrusive and static. Temporize the patient. PAP rule was followed. Finalizing the vertical. Finalizing the occlusal scheme. Anterior groove function was achieved. Open mouth picks. Then definitive restorative plans which I need to do after the temporization. I am planning for keeping the patient in temporary like Dr. Lakshmanan told for a little more time so that patient is okay with his chewing pathway and he is happy with his phonetics also. So what's my plan for definitive treatment is full arch or sectional, master impression, FaceBo and CR bite record, lab work sent with detailed instruction form, BISC trial and bite refinement, cementing and or bonding depending on material selected, final equilibration, bite check, chewing pathway adjustment. Maintenance protocol to be followed, periodic bite checkup, equilibration, scheduled first year quarterly appointments, possible procedures, attending new complaints, scaling, polishing, bite check and equilibration if needed. Second year onwards, 2 half-yearly appointments. Every 4 years, full record and check on FaceBo, CR mounted models. Patient advised to wear deprogrammer during sleep time, long term, not more than 7 to 8 hours. Thank you. Thank you, sir.
Thank you, sir. Thank you for this wonderful presentation. The thing I loved about this is the final protocol and the entire perspective of the case was covered. Did you all watch it, right? From start to finish, everything was phenomenal and everybody's plan is a good plan. So we can't say this, that. Okay, so happy, sir. Thank you. Thank you for this presentation, sir. So with this, I'd like to introduce the next presentation, Dr. Mahendran. Okay, he wanted to always escape from ODD. He wanted to find all the ways to get out of ODD, get out of our sight, but he doesn't have an option. Okay, so thing is, he is so busy, he doesn't want to complete anything in ODD. He says, sir, I understood, I know how to do the case. Why do you want to unnecessarily burden me with all this exercise case presentation? He was very clear. Sir, understood, sir, leave me. Why do you want to torture with exercise? Do you understand what I'm saying? His feeling is, sir, I understood, I know how to do a case, I know how to earn a money. Why do you want me to submit a case? Why do you want me to do an exercise? So with all the torture what he has given me, okay, great. Thank you. Thank you, Mahendran. Start.
Very good morning to one and all present here. So actually, I told to Dr. Ramesh, I don't want to present a case presentation here. But he convinced me like anything. He told me to present in Tamil, I will translate it. But he leave me like in the corner of the room. So, okay. I'm Dr. Mahendran. I'm from Ramanathapuram. Like Dr. Ramesh and Malar ma'am, Vasant sir told, like, proud to be a general dentist. I'm also proud to be a general dentist. So excuse my English. So little bit Tamil will come. So okay. Okay. So actually this was a wonderful course. This is my first occlusion course, not like occlusion, sorry. லக்ஷ்மணன் சார் உங்களை பார்த்தோன்னே பயமாக இருக்குது சார் இங்கே மேலேருந்து பார்க்க. ஸோ சாருக்கு மாதிரி இது நிறைய கோர்ஸ் கிடையாது, ஃபர்ஸ்ட் கோர்ஸ். ஸ்டில் கன்ஃபியூஷன் டவுட்ஸ் எல்லாமே நிறைய இருக்குது. ஸோ ஆஃப்டர் தேட் நிறைய கேஸ் பண்ண அந்த டவுட்ஸ்லாம் கிளியர் ஆகும்னு நினைக்கிறேன். ஓகே, வில் ஸ்டார்ட் த கேஸ். ஸோ ஆக்சுவலி இட்ஸ் அ இன்ட்ரெஸ்டிங் கேஸ். த பேஷண்ட் Mr. Farouk, his family is my patients. Everyone is my patients. But when he come to my clinic, actually has a very difficult skeletal class 3 complaints. So whenever I am seeing any class 3 cases, like in orthodontics as well, I am seeing any class 3 cases, I always avoid that case because I don't know what to do in class 3 cases. So like that, I avoid him. He went to another dentist. Again he came back. I avoid him. Again he went to another dentist. Finally he get the treatment from another dentist in MIP dentistry, but he is not satisfied. Actually he doesn't have any muscular pain or TMD pain, whatever, but he has a skeletal class 3, he is not able to chew properly. Exactly. This is what at the time of present. He has multiple crowns and lowers. In MIP dentistry, he is not able to chew properly. So we are trying to bring his mandible to CR. But when in the consultation room, he is able to bring his mandible to back to CR. So at that time, I in the case because he is able to do CR easier. So I can take this case. So start the procedures like impression, CR bite, Facebook record, everything. In CR, patient can able to bring his mandible to back. So posterior full space irunchu. So enough space for posterior restorative, but there is no space for anterior couplings and all. So we are planning to raise the vertical because sir is addressing me to do the proper treatment vertical. So here because of decision made to lose contacts and increase the vertical from CR, because there is enough space for posterior, no space for anterior to create anterior coupling. That's why we are maintaining at CR position. So we have to rise. Patient has reverse overjet overbite because of skeletal class 3. In CR it became to class scenario 1. So to establish case scenario 2 or 3, we have to rise little bit 2 to 3 mm arbitrarily. So as well as the restorative convenience, in CR there is enough space for posterior restoration. For anterior coupling we have to rise a vertical, as well as the aesthetics and the phonetics. So lab instructions form, same what other doctors are saying, like that, the programming, the articulator, vertical, everything has been given to the lab. This is what I got from the lab. So proper anterior guidance and posterior occlusion and groove function occlusion, everything. So temporary has been made. It's delivered to the patient. Sorry for the photographs because I didn't take it from the DSLR or anything, just took from the phone itself. So after putting the temporary, patient is very happy. So tremendous changes from this to that. His family is very happy about his smile and bite, everything and all. Still in temporary session because he went to religious work. So when he came back to our clinic, we will do the proper definitive prosthesis. Patient is on vacation, so not able to complete the case. Once he returned to ready for final prosthesis means start with the crown preparation. And PAP rule will be followed. Achieve anterior guidance and make all the dots and lines. I will present. In next symposium, I will present this case very proper way. Okay? Thank you. Thank you. So, 5 minutes la முடிச்சிட்டேன் சார்.
Super he has done really well. No, just give him a good round of applause. No, he said he has not done any presentation. He is speaking like a seasoned orator here. Okay, so great, but very, very safe. No, putting it on temporary. Later I'll complete. I will give the guidance and I will give the dots and lines. Very nice.
Thank you so much for this wonderful opportunity, sir. Dr. Vasan sir, Dr. Ramesh, Dr. Malam, Vijay ma'am. Thank you so much.
Thank you, Mahendran, for doing this for me. Thank you. Wonderful. Yeah, great. That's a point here, no? See, he was about to say that point, sir, but he was waiting for you to speak. That was there in his presentation, which I removed. Okay, Opa? Samalista. Okay, right. Okay, so with this, let's go to one more presentation. So by the time coffee will be ready, so get ready for this. So I don't want her to wait. So when I remember Ankita and Ishwari, I remember one important aspect. Can somebody say what it is? Yeah. Wherever they are, you have a bag of snacks. Okay, you will be lecturing, you know. So lecture will be going on here. I'll be taking class. In between, if I go in between like this, no, they'll just give me one snack, sir, because I found them, they're eating. Now I have an option, either to catch hold of them, stop eating, or I have to take. Many times I was hungry, so I thought like, so they have a bag full of, I know how many kgs, I don't know. They have a particular pattern. When they travel, they have a separate baggage where they'll bring all the snacks. Not for them alone. They'll eat the majority. Remaining, whatever that is remaining, the entire batch will share. She is another great clinician. Please come. So, at this situation, okay, in pregnancy period, traveling here is not easy. Thank you for making it, Angita. It's very, very, very special. Junior ODD, junior is also... already we have done enough. So with this background, she is phenomenal. One thing I'll never forget with Ankita and Ishwari is, it was on the second hands-on. Everything they completed. I don't know what work to give them. After finishing everything, everybody was working something. They are coming and standing. Sir, what should I do next? I don't know. Seriously, I don't know what to give. Then I gave them Stuart lift, do it. Even that also they finished. Then I said, do it on the other side. That also they finished. So it was like phenomenal application of the knowledge. That's something which I'll never forget. IDA Baruch, after my lecture, these two girls comes to me, they came to me, they just tell me, sir, we both are prosthodontist. Okay, so why they didn't teach us all this in MDS prostho? What answer do I have? So that is something very, very emotional moment. They are really shattered at that time, so happy to have you, Ankita. Seriously, I wanted Ishwari also to present. But she said, okay, next time. Okay. She's tired. You want to give her something to eat? No? She's seriously saying no, sir. Okay. Ready? Yeah? Talk something, no?
Yeah.
Okay, nahi.
Good morning, all. It is because of God and Almighty and my mentors, Dr. Vasan sir, Dr. Ramesh sir, and Malar ma'am. I could travel this wonderful journey of ODD. Thankful all of them for this journey. This is my case presentation for full mouth rehabilitation with crown bridges and cast partial denture with precision attachments. Details of patient name 54-year female patient, and on muscle examination spasm present with masseter muscle and complaint of missing teeth and faulty processes. Occlusal disease sign attrition with 313233, 34414243, carries with 38 and missing with this one, crown with 21 and 22 joint and FD with this thing. Based on the sign and symptoms related with spasm of masseter muscle, patient had been given chairside anterior deprogrammer, and later after she left little relieved from muscle pain, she has been explained about ODBA test. This is a front view, lip closed and smile, right profile. These intraoral photographs, front view bite closed and front view bite open. We can clearly see the sign that attrition in lower anteriors and missing tooth in uppers. Right lateral view and left lateral view. Upper occlusal view, lower occlusal view before starting any treatment. overjet and overbite view. This is a pre-op impression, upper lower impressions, upper cast, lower cast, Facebook transfer, upper cast mounting with Facebook, deprogrammer in patient's mouth, first point contact in patient's mouth, first point contact on cast. This is my treatment plan. In my treatment plan, old crown was removed and RCT and post-encode done with 1, 4 and 3, 8. Extraction done with 1, 3 and 2, 3. Crown preparation done. Tentative treatment vertical has been decided by restorative convenience, aesthetic phonetics and lip closure. After giving deprogrammer and removing the old crown, I decided to make a equilibration jig and removal of equilibration jig made after removal of old processes to maintain CR while doing preparation. At that time, took CR record and maintain it until end of last tooth preparation, which one was holding CR and did posterior bite in CR with modeling wax of edentulous area. Then after taking edentulous posterior bite registration, maintaining CR and done last tooth preparation, which one holding CR and at last took anterior bite registration in CR. This is my impression and cast after preparation, Facebook transfer and record. Mounting of upper cast with Facebook and lower with CR record, bisque trial. This is occlusal adjustment on bisque trial processes. Final processes in patient's mouth. This is front view before and after. We can clearly see the overbite correction. Right side functional and non-functional. Left side functional and non-functional. Post-op photographs. This is a front view, lip close, front view smile. This is before and after treatment photograph. Happy patient. This one is my upper arch before treatment and this one is my lower upper arch after treatment. Lower arch before treatment, lower arch after treatment. Overlay deprogrammer had been given and recall after 15 days for follow-up. Patient asked to maintain hygiene. Electric water flosser has been advised. Patient come for follow-up and regular checkups is going on. Thank you, everyone.
Thank you, dear. So happy because she made it a point. She wanted to do the presentation. So nobody will prefer doing a case, documenting all this, traveling all the way from here. I thank your family especially for allowing you to come. Okay, it's not easy because I personally know the situation she is. With this, with a smiling face, nobody can come and present a case. That was so happy to see a cast partial case in FMR, which is something we all love. Right, thank you for that. Can you give a good round of applause? Okay. So all the other things, whatever small things, one small corrections we said, never use that wax, use wax wafer. All this has been already conveyed. Here it is not a place to judge. So it's just like whatever they have done, they are authentic, they are true. So from here, whatever take-home points, what sir has suggested for your presentation, take it and make it a point you don't repeat any of those things in the future cases. Okay. So with this, I'm going to introduce our next professor, Dr. Hemani. So she is also, more than her mother knows us very well because of the online torches what we give. Okay, so every house knows us very well, right? Everybody know our voice? On a good note or bad note, I don't know. Okay, so with this I introduce Dr. Hemani. She is like very sharp grasping power. She'll just take time, look into us, and she'll just grasp it. That is something I love about Dr. Hemani. With this small introduction, I want you to start your presentation. She said she's going to finish in 2 minutes. Let's see.
Thank you, sir. I'm Himani. I work as a senior lecturer in Savita, and I have my own practice in Kilpok, Chennai. My mom is Vasan sir's junior, very junior to sir. And when I was doing my master's, she was all the time behind me, and she was very much wanting me to join the course at that time. But against my HOD's wishes, I cannot do that. So after I finished in 2023. So in 2024, I wanted to join in the first batch. In the time of February or something, they had a batch, and I wanted to join. But I couldn't make it that time, so I joined the next batch. Before my first hands-on, the previous night I lost my grandfather, and then I couldn't attend. With Vijaya ma'am's help, I joined the next sixth batch. Thank you so much, Vasant sir, Vijaya ma'am, Ramesh sir, and Malar ma'am for helping me and guiding me through this journey. And I also want to thank my batchmates. They have been a wonderful batch, and I enjoyed my time with you all. Thank you so much. And I'll start my presentation. So my case is, yes, definitely I do. So my case is about an equilibration and restoration work. I just did it till wax up, and this morning I had a call from this patient. They wanted to get started with this case as an FMR. So I think it's very nice that way. So my patient, Mr. Shanmugam, he's a 65-year-old gentleman, and he just visited me for a general checkup. He had no complaints, and there were only signs, no symptoms from the patient's end. No history of systemic illness, nothing. And these are the pre-operative photographs. Sorry for the photographs. It was taken with a phone. Protrusive records, lateral intrusive, right and left records. There were interference, both anterior interference, working side, and functional and non-functional interference were there. OPG. On comprehensive examination, signs were there but no symptoms. TMJ and muscles had no obvious findings. Chronic gingivitis was there. Missing 3646, mesially tipped 3747. Cervical abrasions, playing of upper anteriors. Attrition was generalized. Left side, patient had canine guided with interference, and right side was again canine guided with interferences. Impressions, record models, Facebook transfers. Articulation in MIP. Deprogrammer was fabricated extraorally and then given to the patient. Intraoral photographs were not added in this presentation. First point contact, mounted die cut models, equilibration sheet, CR contacts after few times, and then final CR contacts and dots and lines. After which I did a wax up. Actually, I had some challenges. They were both from my side and from the lab side. The die cut model was cut very wide, so it was not actually approximating perfectly. There was a larger cut, and then while equilibration, I removed a little bit of CR contacts from 2-3. So I had to manually wax up, and I had to build the contact. The other blunder I did was to use a blue wax, because the articulating paper I used was blue, and by mistake I did that. And then while starting with the face bow, I used this model to make indentations on the face bow, on the transfer rod, bite fork. And then I transferred it to the patient, which I shouldn't have done. So marks of that green stick, or stains of the green stick, was there in the model. So it looks a little clumsier. And then protrusion, lateral protrusion, right and left in the model. This was my treatment plan. Re-RCT is required in 1-1, followed by RC in relation to 3747. Equilibration intraorally with equilibration plate. Tooth prep, temporization, final composite restorations in relation to 3413 and 21. Equilibration with the temps. Review with the temp, master impression, final crowns, bisque trial with equilibration, and final crown cementation in segments. So this is my treatment plan and execution. This was my journey. Thank you so much.
Thank you, Hemani, for obeying to present. Okay, that is the level we have to push her to do this presentation. Thank you for this. So with this, we'll have one last presentation before coffee break. Okay, so Dr. Sarita, I get a phone call when I was traveling in Mumbai in a cab. I get a phone call from one of the doctor, and doctor happens to be Dr. Sarita. Sir, I have a case. I have a problem. I did an ortho. I had a patient is saying it's all because of you. Okay, so that was the right words what she spoke. So I couldn't help her at that time because already everything has been done. So the power of documentation, what you do before starting an ortho is very, very important. I hope she understands the importance of documenting everything before. Patient is having deviation, click everything, you don't make a note of anything, you just give the case to an orthodontist, it's a problem. You're going to land in a problem. So that is how our meeting, she is my colleague, she is my, we all have grown up with dental business matter with our great mentor, Dr. Manish Chitnis sir. I'm very much thankful to him. Wherever is the stage, I have to mention his name. So he is so special to me and many of us. So we DBMeds are like everywhere. Wherever the top class things are happening, you can see at least 2 or 3 people sitting there or presenting there. It will be in either of that place. That is the beauty of that DBM tribe. So I welcome you, Dr. Sarita. So the stage is all yours.
Good morning, all. Today, as everybody is presenting their cases, I'll be presenting a case wherein I have done some equilibration and a restoration. So this is a case of equilibration and restorations. So as the roadmap which has been given to us by Dr. Vasant sir, the 7-step formula is prepared for each and every case. That is the thorough clinical assessment, that is the OBDA test, followed by treatment planning on articulator, diagnostic wax-up, test drive and documentation, case presentation, that is discussion with the patient to go ahead with the case, clinical execution of the case, and the patient journey celebration, reviews, and the long-term follow-up of the case. So in the comprehensive examination, we do comprehensive assessment for the TMJ. This is my case. He's a 47-year male with chief complaints of sensitivity in upper anteriors, along with translucent looking teeth. He had dark halo-like thing, which he was not comfortable with. He's a known diabetic under medication since last 15 years. The extraoral photographs with, without smile, profiles, lip support, and incisal display was recorded. These are his MIP and lateral views. The overjet. Then the comprehensive assessment for TMJ was performed. There was no abnormality detected with his TMJ. Load test was negative. In muscle assessment, anterior temporalis was tender on both the sides. It was mild tenderness seen on both the sides. In the assessment of teeth and periodontium, he had history of restorations done with 14, 15, 16, 24, 25, 26, 44, and 45. Had abfraction defects with 46, 44, 45, 34, and 35. And palatal wear with 11, 12, 21, and 22. He had a group function occlusion involving lateral incisor on the right side and left side with the central incisor. Periodontal charting was performed and there were no periodontally involved teeth. OPG also did not show any signs of periodontal diseases or any TMJ related issues. A CBCT was also performed for implant site preparation. The second step is treatment planning on articulator. This helps us to define the perfect way how we are deciding upon the treatment. Impressions were recorded, faceboard transfers, CR bite after deprogramming, articulator upper cast mounting, lower cast mounting, and the articulation. Before we start any treatment ahead, we have some checkpoints to check whether the articulation has been done proper. This includes the first point contact verification. In this case, it was the mesiopalatal cusp of 1/7 in the mesial incline. So the vertical pen reading at CR was 3 mm, vertical pen reading at MIP was 1 mm, the slide was 2 mm. The patient had lower anterior crowding and the patient has less overjet. The patient did not want to go ahead with orthodontic treatment. So restorations were planned. Equilibration was done on the cast. As we had to create some restorative space in the lower anteriors, incisal and labioincisal reduction was done with 3-1 and 4-1. This is the mind mapping. Indirect restorations were, palatal restorations were planned for 1-1, 1-2, 2-1 and 2-2. And direct restorations were planned for 3-1 and 4-1. Apart from that, lower right 6 was planned for an overlay or a crown, and 3-6 to be replaced with implant. This was the lab instruction form. All the information, including the articulator programming, the required occlusal scheme, and the material of choice, the shade selected, and the attachments, whatever was sent, were informed in the lab instruction form. Step 3 was the diagnostic wax-up. Palatal wax-up was done on 1-1, 1-2, 2-1 and 2-2. Implant crown wax-up for 4-6 and overlay for 3-6 was planned. Lower anteriors were also reduced and given a wax-up there. Step 4 was test drive and documentation. Unfortunately, this case we couldn't complete in time. So once the patient consents in for the treatment, after the test drive or the pro-tem transfers are done, we can go ahead with the actual case implementation, which would be transfer of the wax-up. If the patient is ready to go ahead with the treatment, with the equilibration plate, equilibration will be performed intraorally. Post that, the impressions will be taken for the preps for 1-1, 1-2, 2-1 and 2-2 and 3-6. After that, Facebook record is done, CR is recorded, and once again this thing is sent to the lab. In the next appointment, the indirect composers for 1-1, 1-2, 2-1 and 2-2 will be bonded along with the overlay or the crown with 3-6. After that, an implant would be placed in the region of 3-6, which would be loaded as per the occlusal scheme decided after 3 months. Next would be the patient review. Follow-up appointments will be checked for any kind of discomfort, interferences, and impressions for deprogrammer would be taken. I'll prefer giving a NASA for nighttime wear initially. And the regular follow-up will be maintained for monthly for first 3 months, 6 monthly for a year, and yearly thereafter. Every time the records would, the photos and the records would be maintained for a long-term review of the case. This case can also be done digitally. So intraoral scans were recorded. Bite at MIP and bite at CR was recorded. Intraoral data was integrated with the extraoral facial scan, and a digital articulation was done with the references from the extraoral scan. A digital wax swap was performed along with the reduction points mentioned in the scan. Implant placement was planned using Blue Sky Bio software. Again, the similar path goes ahead with the test drive thing, silicone indices and test drive. So this is the appointment schedules. A long-term follow-up is required for any case to check for the any further occlusal derangements are going on. Thank you all. Sorry, I'm not very used to do any kind of presentations. Thank you.
It doesn't seem to be that way, right? So she gave a good round of applause for her. No, great, 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 Sarita. So happy to see it is so systematic. She gave both the perspective. So something you have to embrace. Digital is not future. We always say it's already there. So we have to get accustomed to that. And she is always there. Artex, digital format. She want to implement. If there is something you innovate, you learn something, you discover something, please let us know. So that we'll incorporate in our curriculum also. Okay. Thank you, Sarita. So we'll have a. So we don't have to be so serious like this, sitting and observing about CR. Okay. So we can be little relaxed. This first bench will always be serious. We are forced to be like that. So just enjoy the presentation. Okay. So have fun. Okay. Otherwise, hearing the same thing, impression, Facebook record, equilibration, chart sheet, mind mapping. By the time you finish the lecture, you'll say enough. I know the procedure. Please live it like Mahendran. Okay. Do you understand? Okay. So we'll have a short 10-minute break. We have very less time. Please go and come back. And Dr. Shruti Goyal will be the next presenter. Please get ready. Yeah, sharp 11 o'clock. Whether nobody is sitting here, we'll sit and Shruti will start presenting. Okay? Dr. Shruti Goyal. So what can I say about her? I can say 100 things about Shruti. Okay. She is basically from batch number 2. From there, she never gave up the process. She never gave up the journey. She made it a point she has to do this job and complete it. Okay, so I all the respect, and she is like she doesn't decide something. I am lifelong. I am thankful to Shruti for keeping me in contact with Dr. Manish sir. That is something I'll cherish for life, because she showed me the path where you have to meet some great people. It's a wonderful tribe. Okay, so Dr. Shruti Goyal, phenomenal clinician, and she has a wonderful practice. And her growth, I have seen from scratch, from start till today, where she is. I'm really proud of you, Shruti. Thank you for coming back. Okay, so let's start your presentation. I don't want to waste time.
Good morning, everybody. I'm Dr. Shruti. I am an endodontist. I've also completed my POS graduation, so I'm doing ortho work also and implants. And most of all, I am a restorative dentist with a stomatognathic specialist, thanks to ODD. So I'll start with my presentation. So this patient had traveled to us from Singapore, and he had a complaint that he had missing back teeth. He wasn't able to chew properly. He wanted his teeth back. And on questioning him further, he also wanted to improve his smile. So I was never comfortable doing full 28 crowns for everybody, and this is where ODD had shown me the way, because I have had FMR, I've done FMR courses previously. I've had a lot of training. This was not my first FMR course, but I had never learned what I learned here, how to do FMR in a minimally invasive way, and I'm very deeply grateful to my mentors, Dr. Vasant, Dr. Ramesh, Malar ma'am, Vijaya ma'am, who have helped me deliver ethical treatment to my patients. So this is the smile of the patient. As you can see, there's a lot of wear happening on the incisal edges. The front teeth have abfraction lesions. There is a lot of supra-eruption of teeth. And we can see a lot of signs of wear and tear. Same things can be seen on the OPG. The bite registration, Facebook record. What I like to do is this, what I like to do while bite registration is making a small hole in the coes. Mostly I always like to fabricate a coes, because with Lucia jig, the bite raises too much. So I like to fabricate, although it adds steps, I like to fabricate a coes, and I like to make a small hole and fill in composite resin to lock the bite, because otherwise I've seen while biting, the bite moves. Semi-adjustable articulator mounting, planning. So after this step, we move to the digital protocol. So the bite that I had finalized on the articulator, the way I had finalized the bite was wherever the first tooth was meeting, there was a lot of interference happening on the supraerupted 2-4. So I chopped off that 2-4 because anyways the plan was to reduce the height of 2-4 and 2-5 to get restorative space for the lower premolars and molars. So I chopped it off, and then we got the first contacts, like the later contacts on the back teeth. 2737, I got the first contacts there, and I kept that as my vertical. So at that point, so the treatment plan was, I will show you in the photos basically. So I got the first point, the contacts on 27 and 37. We had already completed RCT of 24 and 25, and I chopped off 24 because I anyways had to give crowns over there. And then I made a jig over here and scanned this bite. This is called a verticentric bite, where the centric is fixed and the vertical is fixed. So the main difference between analog and digital world is that in analog world, the lab can change your vertical. But in digital world, the vertical has to be scanned and given. So you can see there's a little bit of gap in the anteriors that will be filled by maybe crowns or taco shells, V-shaped veneers kind of restorations in the front. And rest everything, we are not touching anything extra. 2425 anyways, they had to be, RCT and crown had to be given to get restorative space for lowers. Implants were planned in 3.5 to 3.6 region. 3.4 to 3.6 region. There was another implant planned on 2.6. On 3.7, I did a onlay kind of restoration to straighten it up. So on the mesial edge, mesial surface, and on the occlusal surface, we had planned a restoration. And on the right hand side, in the lowers, we planned a bridge because there was not enough space for the implants. Then for planning the anteriors, like the most important step is where has to be the central incisal edge position. So that was planned with DSD, keeping in mind the aesthetics and phonetics. This photo was given to the lab, and the lab then planned a digital mock-up. So as you can see, like we did not touch any posterior teeth in the first quadrant. We did not touch the lower anterior teeth. Only the teeth which needed treatment were done. So this wax up was then transferred in the mouth, and we corrected the guidances in the temporaries, and we scanned the temporaries. Then I prepared the anteriors and made a jig, and then prepared the rest of the teeth and scanned with the jig in the mouth. And the scans of the prep teeth were sent to the lab, scan of the adjusted temporaries was sent to the lab, and the same temporaries were then we asked the lab to replicate those so that we get the same guidances. So these are the preps, all of it was done in one single sitting. These are the post-ops. So just these implants are left because we had done a sinus lift. We had done GBR in the lowers. So these will be restored in August. And rest of the case is complete. After this, I'll be giving an overlay type of deprogrammer. I would like to thank my mentors for teaching me to see full mouth dentistry differently. I would especially like to thank Dr. Ramesh because there was a lot of time when I felt like I will not be able to finish this course because at one single point of time I was doing four year-long courses together. There was POS going on, there was ODD going on, an implant course going on, and also DBM. So it was a lot of overwhelm for me, and I kept on getting scolded from my husband that you have taken so much on your plate and you are not able to give time to anything. And it was a very difficult time period for me, but I'm very, very thankful to Ramesh sir because he always kept on making me accountable. How much have you done? And I want you to see you finish it. And that is the only reason I finished. Otherwise, I was feeling that I've learned what I had to learn. Now I can, like, there's so much going on. I can, maybe I didn't even, like, I couldn't understand if I could complete it. Even on 10th of June, which was the last date, I had some exercises remaining and I was feeling, I don't know if will be able to graduate this year or not. And I'd message sir that I'll finish everything by 15th or 20th. But I finished everything on 11th by God's grace. And I would like to thank my friends from ODD, Dr. Ankit, Dr. Mansi, Dr. Shweta, who helped me wherever I got stuck. I would not have been able to finish this without their help. And my team, who did everything for me, my mountings, my assistant tells me that he can now mount in his sleep also. So these exercises were, even though they were very overwhelming, there was a lot to do, but they have helped us in becoming very, very confident with doing all these steps. Otherwise, in other courses, we learn. But when it comes to doing, you feel very not confident in doing those. And that is the reason, like, even Lakshman sir was sharing that he had attended many courses, but he could not get anything from there. Why we learn from here is because we are made to do all these exercises. And even the second hands-on, the exercise for treatment planning, for giving the patient how many appointments, that was very, very helpful for me, because whenever patients used to ask, I used to give very vague answers, but that exercise really helped me with patients. Thank you, sir. Thank you so much.
Thank you, Shruti, for this phenomenal presentation. So happy to have you. Thank you for coming all the way. Okay, great. Thank you. So with this, we'll go to the next presentation. So you all like this presentation? What did you like? Okay, fine. So every time I'll message, Shruti, what stage are you? She'll give one reply. I'll do it, sir. I'll finish it. I genuinely wanted to help. That's why it's not like a copy-paste message what I'm sending, right? So I genuinely wanted to help. If there is one person who didn't even ask a single help, sir, give me this, give me that, I'll do this, that, nothing. She said she'll complete. She said she'll come. She conveyed that she'll be finishing by this day. But before even looking into everything, I gave a deadline and she finished well before everything. Thank you. Hats off, Shruti. I'm very, very proud of you. And here comes my next person. Wherever I'm going, she'll be there. That is Sauda for you. Okay. So in Kerala, wherever I was there, Sauda will be the first person before even. So she'll fix another course. She'll be learning there. Okay. Whenever break time comes, no, she'll be sitting in this course, in the IDA program. So that's how much respect what she has. Welcome, Dr. Sauda. Please come. So happy to have you here. And she is like, she'll sit on your shoulder and constantly you have to answer her. Unless you answer, unless she understands, she'll never get out of your shoulder. She is like a terrible mentee. She wanted to learn, she wanted to understand, she wanted to apply. Till then, she'll not leave you. Okay, that is Sauda for you. The stage is all yours, Sauda. And thanking sir, your husband. She wanted to give half of the certificate to him. During graduation, I said, like, better I'll give the certificate to him, you stand next to him. Okay, Sauda, thank you.
Thank you. Very good morning, everyone. Really happy to be in this auspicious occasion. And especially thank you, my dear mentors, because of whom I'm standing here today. So my case, it's completely an equilibration case. So some composite restorations also have done. Before coming to this course, I think like FMR is completely crowns. So this case is a minimally invasive FMR where I have maintained the functional anatomy of the tooth, and at the same time, we are able to give a good static, stable occlusion for the patient, and by which the patient's chewing efficiency is formed better. So patient name is Raihan. Raihan is my patient since when I'm studying in Pariyaram Dental College from the pedo department. He's my patient. From there, he is there with me till he is now 16 years. So I know his journey through which all conditions he have gone through. And actually his complaint was nothing. He just came for me for his review for the Hollis retainer. He's wearing his Hollis retainer since 8 months. So he just came for the checkup. But I want to do my equilibration case to present here. So I'm searching for a equilibration case, best case. So what I thought is, I'm just asking him, Raihan, do you have any complaint? Do you have any chewing difficulty? Do you use the both sides? So the patient was replying me like, doctor, I use only left side to chew. On the right side, I don't feel comfortable. So since many years, I'm using only the left side. So I just checked this occlusal status. By checking that, I understood that he's not getting a right contact on multiple tooth on the right side. He's having a minimal contact on the left side. And also, even that contact is more on the molars and less on the premolars. He have no medical histories and all. And he has done 3 tooth for RCT, and he has a history of tongue thrusting. He is wearing tongue guard since many years. So we started the ortho treatment with an anti-open bite on the centrals and laterals. So we finished it by the same way. So tongue occupies that space. He's chewing patterns, and there is a dental caries in 2-2. RCT is done for 1-1, 2-1, 3-1. And the main thing is he's not having any functional or non-functional interferences on both sides. There is no protrusive interference. But he's also having the canine guidance on both sides, right and left, canine guided occlusion. But he's not having a static contact on the right side. And his protrusive guidance is by only 1-1 and 4-1. The left side centers were not guiding them. So in my thought is, when I am touching this case, my thought was I want to give a best static contacts on all tooth, and I would do a static contact on the canine from which the guidance should start, and at the same time I should add little amount of composite on the lower left side center incisor to help in the protrusive guidance. There is no TMJ issues, no muscle issues, and tooth we have already discussed. This is without smile, with smile. This is with the photo with retainers, upper, lower, and MIP position. Because there is no bite on the anterior open bite, even his mamelons were there still. Lower incisors. There is no functional or non-functional interferences. There is no protrusive interferences. Overjet, you can see here, it's an open bite. On the right side, canine also is not having a contact. Then we started with the Facebook transfer, coils reprogrammer, centric record. Then first point contact in patient mouth is like on the central cusp tip of the lower 3-6, and it is getting on the mesial slope of oblique ridge of the 2-6. Co-discovery with the patient was, I just informed them it is just the continuation of ortho treatment, because I don't want to lose the patient by saying the payment or anything. So I don't just informed about any payment or payment. And the patient is just passed out with 10 standard. So he's having enough time because he's waiting for his admission. So time doesn't matter, payment doesn't matter. So, and also they were ready to get into the follow-up and all. So I have taken up this case. Facebook, then upper articulation with Facebook record, lower with centric, and yes, we have got the first point contact as they must have tough patient mouth. Then planning an articulator. Actually, the first point contact is like -3. This is my equilibration chart sheet. The first point contact is -3. And there's, this is the mapping, equilibration for all teeth. He's missing 8. Vertical at CR is -3 and vertical at MIP is -4. So the slide is only 1 millimeter. After removing the posterior segment, we got the static contacts on the right side and left side of the canine. So we plan to retain the contact, but by replacing the posterior segment, I got only the static contact on the left side, not on the right side. So I'm thinking, okay, let's see what will happen. And finally, if we need it, we will add a static contact by composite or something. So, and because all the anteriors in a case scenario 3, so even we want to make it contact, we can make it by adding a labiolingual or palatal composite restoration, but we don't need a static contacts on the lower anteriors, means centrals and laterals, so we will keep as such. So initially I have got contact, I have reduced the first point contact on the central cusp tip, which is my first point contact. I have reduced the distal stop of the first point contact because I want to move it more mesially. So after removing the first point contact, I got some tooth on contact on the right and left side. And by reducing the 2-4, I got more number of tooth in contact. And now what I've got many tooth on contact. Then what we decided, only 2 more tooth left without contact, without a static contact. So we are planning now to add the contacts. Next, we have added the 4-5 distal fossa and also 1-3. 4-5 we have created a landing pad. So we got the static contact on the 4-5 and the upper palatal cusp tip of the 1-5. So this is how finally we got all the contacts. We have got all the contacts where we need, all static contacts is achieved. And next we are going for the guidance. So I got the canine guidance on the both side and protrusive guidance by the centrals. And now it is equilibration in patient. Initially, we have placed the equilibration plate. So after reduction of the first point contact, I got the contacts on the 2-6, 2-7, 2-7, 2-6 and 2-5, 2-4. But 2-7 is more intensive. The contact is more. So my next plan is to reduce the outer buccal incline of the 2-6. So after reducing the outer buccal incline, I got more tooth in contact. At this stage, my patient was, I don't know why he smiled at me. He just looked at me and gave me a smile, and he was saying to me, "Doctor, now I feel better. I feel more comfortable." But I was thinking, I have done nothing. I have just reduced something. Why he is smiling at me and telling like that? So he told me, "Doctor, now I feel better. I think I can chew on right side." Okay, then I told him, "So please wait. Let me finish this." So, because I'm confused. Then he got, then after that, only 3 tooth remain, which I don't have any static contacts. So I'm trying to get that contacts by creating a landing pads on 4-5 and 4-6. One thing I have understood is whatever things what we are planning on the articulator is not as same as in mouth. So that also I have learned. So next I have built a landing pad on 4-5. So I have got a contact on the distal fossa. I have created a landing pad, and I have got the contacts on the upper palatal cusp. And next the landing pad is created on the 4-7. And also I have got the cusp tip fossa contact. Finally, I have already told that the right side, the canine is not getting any contact. So I have created a static contact on the canine with composite. So I have got all tooth a stable contact at centric. Next, I want to go for a protrusive guidance. For protrusive guidance, I have had little amount of composite on the 3-1. So I have got the guidance too. This is how I finished the case, because the centrals have got protrusive guidance and lateral protrusion by the canine guidance. Yes, this is how I finished the case. Thank you, sir. This is right lateral protrusion. This is left. It's not moving. This is the protrusive guidance. So really thank you so much. Really thank you my mentors. I have started this journey with the knowledge of zero occlusion. So I don't know even what is canine guidance. So if I have done something here, it's only because of my mentors. I don't know how to express my gratitude here to all my teammates and also my mentors. Really thank you so much.
Wonderful, wonderful, Sauda. So happy. There are two reasons why the patient would have smiled on you. Either they are tired of your equilibration or they would have felt really, really comfortable. Okay, many a times the patient will give up on equilibration, but we won't give up. We want to see the dots everywhere, no? So we strive a lot. They'll come to a situation where, sir, enough, I'm happy, I'm able to chew. Okay, great, Sauda. God bless you, dear. So happy. Because the words, what she spoke on the from zero to here is not easy. It's her persistent, she's phenomenal in the sense, she'll be everywhere here. I'll tell you, no, morning 8 o'clock, if I say, no, she'll be there by 7:30 to come and meet us. She'll sit, she'll learn, and seeing the video was amazing. Thank you, Sauda. Thank you, Sauda. You made us very emotional. Okay, so with this, so I'm going to call, I don't know when this girl is going to cry. Okay, okay, fine. I'll call Dakshayani. She is also like Sauda to us, to the Vasanental Academy. They all like, because of her, Mahendran is here, Pradeep is here. Ottungada. Every time she is not worried about our seat or her course. The biggest regret she'll have, no, why did I say this to Mahendran only brought you here, correct? But she has to bring Mahendran for graduation. Do you understand what I'm saying? So it's vice versa. She has been pulling, she is being around, sir, Mahendran is not doing, Pradeep is not saying, Rafi sir is not coming. All these four people are, no, all are four different directions. And she is the only one persistently, consistently doing everything. And hats off Dakshayani for that. Okay, so with this, you can start your presentation.
And he just motivated because this journey started after I lost my father. Because I was literally broke after my father passed away. Like I need some kind of diversion. So I used to do workouts, but okay, doing a workout, that's going to gym, doing a workout, nothing. Then after joining ODD, like before that I used to listen to Dr. Ramesh's class. That motivated me, like how can something is there, I need to study and I need to divert. So his classes motivated me to join the course. And then, okay, why not 1 year we will dedicate more and divert my father's loss. That still I'm recovering, but because of Sir, Mallar, ma'am, I'm just okay and moving on my life. Thank you so much both. Without you both, and even now they're being my backbone, my strength. I don't know how to express, but I will just shine brighter further and make them proud. And thank you, Vasant sir, for motivating and appreciating my cases. Thank you, Vijaya ma'am. Okay, and my case will be restorative and equilibration, both I just combine. And this patient is little close to my heart because from A to Z, like she's a little bit, whenever we call, she never used to say no, and she used to come. That made us to do at least a month's gap. I just finished till the temporaries. her main complaint is like she had sensitivity. So I just treated her with the root canal, and I just completed the root canal, and we made her to understand that other teeth and jaw, and she has ear pain also. And for past 10 months, she said on and off she gets ear pain, and her teeth are getting broke. So we just made her to understand that we need to address her teeth and in a stable position. And jaw deviation also was noted, but after giving a deprogrammer, she feels comfortable. And the pain is also gradually reduced. So I just completed the chief complaint. And after that, sorry, I lost the pre-op pictures. And these are the extraoral photographs. Sorry. And upper and lower impressions and model mock-up mounting records has been collected, and Facebook records I just took and transferred in the articulator. The upper articulation has done, and the CR bed registration has done, and our lower articulation has been done. Sorry. And the first point contact in mouth and model has been coincide. So I thought, okay, it is further okay to proceed. And this is equilibration chart sheet. I just, after removing the posteriors, like after removing the posteriors, I just thought, okay, the 1-3 and 3-3 is in contact, and I thought, okay, we can retain that, and it's a complete additive case. So I thought of it's in a case scenario 3, so we'll proceed. And treatment vertical, I thought we can have in 6 mm to proceed further. And this is mind mapping. And just gave lab instruction form, like where all to do the wax up. And wax mock-up has been done. And just for the treatment vertical. And with that, equilibration jig fabrication has been done, and upper and lower preparations has done. And I just took verticentric bite and just did a scanning, and upper and lower PMMA crowns has been delivered. And with that, I just took upper alginate impression for jig fabrication, and upper and lower temporary crowns has been cemented. With that, the equilibration we are going to start. After placing an equilibration jig in the oral cavity, and after that, after adjusting the plate, I just got contact in 2-4 and 2-7. And after this gradually doing an equilibration, and at certain time, like some static contacts has to be achieved. So made a landing pads on the force of 1-7, and in 1-5-1-6 in marginal ridge, I have added the composites for the static contacts. Then on the third tap, gradually I started to get the contacts on the remaining teeth, except in 1-4 and 4-4. And we have to check about the anterior coupling. So I have added in the 4-3 and 1-3 for contact, for the static contacts, and linguoincisally in the lowers. And with the composite tabletop, I have added in 1-4 and 4-4 for the static contacts to be achieved. So all the static contacts has been achieved in the temporaries, and dynamic also achieved. But with the protrusive guidance, we have to add in 1-1 and 2-2 for the protrusive guidance to be achieved. So I have added, this is after temporaries, this MIP and open mouth. And this is right and right side functional. This finished in canine guidance. This is non-functional and protrusive. So protrusive, this 1-1 and 2-2 is taking out. And this is left side. And this is with the occlusal marks. This is all with the temporaries. And this given an anterior deprogrammer, and once she is comfortable, then we'll just change to permanent. Thank you. Sorry, I was a little emotional because if I'm talking about my father, I couldn't even move on next minute. I'm just sorry. Just hope you all understood, and thank you so much.
Okay. Thank you, dear. Wonderful. Great to see the presentation, because the best part about our ODD journey, she need a diversion. And what is the better diversion than ODD? Anyway, you are going to be engaged night and day. You can't think about anything except ODD. So that's a very, very strong comeback what she gave. Because we know from where she started. From there, her only option to forget the loss in a family was ODD. This is something we'll cherish for life. Forget about our case presentation, case things, all those things she'll learn by herself. She is already executing to this level with an 1 year work, and with the temporaries, if she can achieve up to this level, so she can definitely do it. The best part is, that's how engaging is the ODD format. Okay, so you don't have to force yourself to finish it in 2 days, 3 days. We gave you enough time. She took that time, and she is also one of the, I told you, 4 or 5 people are ready by February, and she is one among them. So good round of applause for Dakshani. Okay, so with this, I'll call upon the great man, Dr. Prateek. Okay, so he is also like, he's almost like, I'll share like Shruti. So something like that. He understands, he grasps it, he'll take the help. He didn't give me much of a work. That is how I can introduce Pradeep. Welcome, Pradeep. So stage is all yours. Start.
Yeah. Good afternoon. So I have named my presentation starting with an inspiration what Dr. Ramesh sir always says. The name what I have given is PDH, that is Pranu Dental Hospital, FMR, Full Mouth Rehabilitation, 1001. So I strongly believe, sir, maybe down the lane in 2 years, the 1 in the starting will become 2, and I'll make you all proud. Yes, it's a full adhesive case, what I'll be, and yes, full adhesive case. So start off with a small quote, known as a drop and unknown as an ocean. So my introduction is over. So yes, I come from a place in Andhra Pradesh called Tirupati. I think this tells all what it is famous for. Yes. Coming to my case presentation, comprehensive examination. The patient came, walked in. She's a known patient for me for the past 15 years. She walked in with a complaint of pain in relation to her left upper arch. So yes, I think how many of you agree? Almost in every session or every lecture, Ramesh sir says, don't jump into FMR. Treat the chief complaint first. Though she was a known patient for me for the past 15 years, I didn't jump into FMR just because she'll accept whatever I tell. First, what I did, yes, this was a pre-op OPG. She came with a complaint of pain in this premolar. So attended the chief complaint, gave a root canal, called her for an appointment for crown. During that sitting, I told, madam, if you just give you a crown, I might solve your problem for now, but your chewing efficiency will not improve. You'll not be able to chew. If you really need to get over it, there is something known as an other way of dealing with it in a very systematic manner. If you give me permission, we'll go ahead with it. So yes, it was a big yes from her. So the TMJ muzzle examinations were done, and she has no other complaint except for signs were that she was asymptomatic. So same way, there was no symptoms in any of the comprehensive examination of the TMJ and muzzles. Her intraoral examination was done. Summary was multiple missing teeth and root stems, and wear facets, attrition, all were seen. So extraoral records taken. She hardly smiles, so I promised her I'll make you smile broad. So left profile, right profiles, intraoral records. You can see the attritions, wear facets, fractured restorations, fractured tooth, all a root canal treated 1.5. The lower, the occlusion, present occlusion for her. So the right lateral functional and left lateral non-functional. Same way on the left. The protrusive movement. The overjet overbite record. Yes, treatment planning done. Explain to the patient that we need to further go ahead with a test known as an ODBA test. So upper and lower impressions taken. Facebow transfer. CR bite recorded. The first point contact was in 3.5. Articulated. Same 3.5 was recorded. So since it was a full additive case, The treatment plan was given for the patient. The upper was 2.5, a root canal treatment. And she insisted in removing the old FPD in relation to 1.3, 1.4, 1.5, 1.6, as there was foot stagnation for her. So we planned for crowns from 1.6 to 2.5 and implants in relation to 2.6. In the lower, extraction of 3.5, 3.7, composite buildup in the anteriors, and implant-supported prosthesis for the posteriors. So yes, again, in every session on every case, so insist on telling the treatment plan and the cost to the patient. The cost was explained, concern was taken. I thought she would be shocked. No, she accepted. We proceeded with the treatment. So the models were sent to the lab instructions in which articulator I have articulated, what position I have, what kind of occlusion I have articulated relationship, the H angle, the Y angle, what mock-up to be done, what shouldn't be done. So every case, if I have a doubt, the kind of content given in our portal, the answers are there in it. I think most of us agree to it. So FMR, total adhesive case, I went back, saw Sir's video of the FMR case with total adhesive. He has clearly mentioned, please mention which teeth not to be mocked up. So mentioned all those particularly, then gave instructions to the lab, the kind of cusp angulations, what I wanted, what kind of occlusion pattern I wanted, all the instructions meticulously written and sent to the lab. Before I got the mock-up model, planned for certain treatments, extracted 3.7 and placed implants, this is quick dent TPR implants, cortical engaged TPR implants. Mock-up received. Yes, we planned something, God planned something. Unfortunately, the patient's brother died. She didn't turn up for any other follow-up. So mostly she would be coming in this week for the further follow-up and further treatment. So it'll be done. And sure, sir, in the next symposium, I'll definitely, if given a chance, I'll be posting it. So all my presentations, I need to mention about these two people. My uncle and my aunt, Dr. Prasad and Dr. Anuradha, they are the guiding forces or guiding light behind what I am in dentistry today. And of course, this is all because of these four people, Dr. Ramesh sir, Dr. Malar ma'am, Dr. Vasant sir, and Dr. Vijaya ma'am. Thank you one and all for this great opportunity. Sir, this is just my beginning. I will sure I'll reach great heights and make you all proud. Thank you, sir. Thank you.
Thank you, Pradeep. Thank you, Pradeep. Thank you for this. Okay, finish the case and update. But I don't know whether I can hold you accountable from today. The moment you get the certificate, I think people have set, in Tamil we call Adiyal. You know Adiyal? No, boy. Huh? They're waiting for me to step out of lemon tree. I don't know what they're going to do. Okay, so with this, we'll go to the next presentation. I'll call upon Dr. Uma for the next presentation. Okay, I'm just mix-matching cases. Okay, so that you get the entire perspective of it. Okay, yeah, come. So the biggest thing is, I wanted Dr. Supriya. She was there with me for 5 years in my practice. I wanted to join the course. She recommended that course to Dr. Uma. And she has graduated. She is still thinking whether to join. Okay.
I hope she will join the
okay,
next batch.
fine. The best part is sometimes life connects you in different angles. We don't know how we get connected, why this is happening. So with this background, let's start your presentation. Okay.
Good morning, everybody. I'm a little nervous. Okay, this is my first case in ODD journey. My name is Dr. Uma Maheshwari. I'm from ODD batch 5. It's a complete additive case. Okay, coming to the case details, patient name is Mr. Narendranath. He is 62 years old male and he has a chief complaint of missing tooth in upper and lower back tooth region. And the previous dental history was he has done many root canal treatment, some of the root canal treatments with crowns and some of the root canal treatments without crowns, and the medical history was not relevant. But after addressing the chief complaint of the patient presented in our clinic with the chief complaint of missing tooth. But after the comprehensive clinical evaluation done, it was determined that existing dentition required a full mouth rehabilitation rather than treating a limited missing tooth alone. So I decided to take up this case as our ODD protocol. Then I explained to the patient after his complete understanding and patient understanding his condition, and the patient is agreed with our treatment protocol. Then I start this case with our ODBA test. These are all the roadmap for our occlusion-driven FMR. So comprehensive examination of stomachographic system and comprehensive treatment planning was done in semi-adjustable articulator, and diagnostic WhatsApp, test drive and documentation done, and clinical communication and co-discovery with my patient, then comprehensive clinical steps in full mouth rehabilitation, and then patient review. So this is my roadmap for this ODD. And coming to my ODBA test, so after the comprehensive comprehensive examination of stomachographic system, the patient has no symptoms of muscle or TMJ. However, the signs of occlusal disease was present. For example, he has generalized attrition in lower and impacted DC with pulpal exposure and tooth structure loss seen in lower 4.1, 4.4, 4.5 and 4.6. So after this, I took my preoperative photographs. These photographs showing existing dentition. It's a complete additive case, and you can appreciate the lower anterior generalized attrition, and also that tooth structure loss seen in 4.4, 4.5 and 4.6. And this is my MIP front view. You can appreciate the generalized attrition in the lower. And this is my MIP right side. This is MIP left side. And this is the impression was taken with addition silicone impression material, and then my face bow record. And this is the patient face bow record front view and the side views. This is face bow record outside, front and side views. And coming to the CR byte registration, I fabricate a coil-step deprogrammer. This deprogrammer helps us to relax the muscles and eliminate the muscle memory, and also it guides the mandible to the most superior portion. And then CR byte registration was done with wax wafer. And then my first point of contact are seen in 1.3 in the upper and 4.3 in the lower. And then the face bow assembly is transferred to the articulated with indirect mounting jig. Then upper cast is placed and check the clearance for the future articulation. And the lower cast is articulated with CR byte. And these are all the models showing without byte. And this is the model with byte photograph. And the vertical at CR is 1.5 mm. Vertical at MIP is 1 mm. Almost 1.5 mm sliding was seen. And this is the first point contact is coincide with my mouth, patient mouth and the model. And then now coming to the treatment planning. So after articulation, after CR byte articulation, I removed the posterior segment and checked the contact in the anterior most region. So I got a contact in 1.3 in the upper and 4.3 in the lower. But you can see there is no restoration space in the anteriors and posteriors too. So my equilibration chart sheet. So I decided to increase the vertical about 1.5 mm so that I can able to give a decent overjet and overbite. Then a composite restoration to get anterior relation to composite restoration in lingo-incisal areas of upper anteriors. After that, 4.7 and 3.7. So I planned 4.7 and 3.7 implants. So, and the guidance right side, it's a group function involving canine, and left side group function involving canine. Both are canine guided occlusion. And then I fabricate a coil-step deprogrammer with my desired vertical. And I call it as a deprogrammer. So that desired vertical deprogrammer is mounted and check the clearance for the future restorative phase. And this is, you can appreciate the right side clearance seen and also left side clearance also seen. And then that fabricated deprogrammer, which I set my vertical at 1.5 mm, and that vertical and that plate is transferred into the patient mouth, and the verticentric bite is fixed here. Then then a bite wafer placed and CR register. Then composite index was done. And this is my scanning upper lower, and this scanning shows the with bite. And this is the exocall design, provisionals, left side, right side and anterior. And you can appreciate the anterior coupling, overjet and overbite in this picture. And coming to the phase 1, it's a provisional phase. So I fabricate a PMMA milled crowns. These are all the photographs of provisionals, front view, right side, left side. Then the provisionals are placed into the patient mouth. This is upper provisionals, lower, right side provisionals, left side. And all the provisionals are placed inside the patient mouth. Now, the static occlusal dots with red and blue articulating paper was done. And the right side, as we planned, it's a canine guided occlusion. You can appreciate the disocclusion seen beyond my guiding teeth. And the left side, also canine guided occlusion, disocclusion seen here. And this is the protrusive guidance. Coming to phase 2, after the provisional are set well adaptive into the patient mouth. So I decided to move to the phase 2, which is provisionals to permanent. So this is the front view, and this is the upper photograph with permanent. This is the lower, and the right side and left side. So right side MIP photograph, and this is right side functional, right side non-functional, and this is protrusive. Coming to the left side MIP, left side functional, left side non-functional, and protrusive. And these are all the dots and lines, the static occlusal dots with blue and red articulating paper. You can appreciate the lines too here. And these are all my pre-operative and post-operative photographs. And this is my pre-op and post-op in the front view. You can appreciate the vertical has been increased here. And this is my upper pre-op and post-op, lower pre-op and post-op, right side pre-op and post-op, the left side. And the night guard is, I designed a DASA for this patient. So I had to deliver DASA by this weekend, and follow-up maybe every 3 months. And this is my workflow for this case. So I took so much bite for this case for fabricating my permanent from provisionals to permanent. And I truly thank to my great mentors actually. I'm a little scared and nervous actually. Okay, I would like to express my deep gratitude to sir, my mentors. They are very hard to find, difficult to path with, and impossible to forget. Thank for being my part of my journey, sir, in this ODD. And I'm very grateful for your guidance, dedication to push me to do my best here. Always inspiring and always inspiring. Thank you, sir. Vasan sir, Malar ma'am, and Ramesh sir, and Vijaya ma'am. Thank you.
Thank you, Huma, for this wonderful presentation. So happy to see. The take home is she fixed the vertical, she mixed the analog and the digital in a very wise way. She fixed the vertical. In the vertical, she has created a jig and which she has transferred in the mouth. Okay, great. So with this, we'll go to the next presentation. Dr. Venkatesha, you're all screaming for torturing you for 1 year. No, we are torturing her for 2 years. Because that too, she has to be there in, we told you, right? So we went to a college. Do you remember something we said? A curriculum has been incorporated in Vishnu Dental College. So already she has been there with us in that entire year. And again, she wanted to feel the same torture and she joined again. Okay, so welcome Dr. Venkatesha. She is very, 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 very disciplined. You can think about it now. One college, after 1 year of curriculum, out of professors, assistant professors, everybody sitting there, selecting one person from that entire batch and sending for a advanced course. Then you know the value of her. I don't have to explain. No, welcome dear. Please come.
Yes, good morning all of you. Sir, first of all, thank you so much for all the mentors, Vasan sir, Ramesh sir, Malar ma'am and Vijaya ma'am for your constant guidance, support in the course. Thank you so much, sir. Thank you. Today I am going to present a case. I am Dr. Venkatlakshmi, Senior Lecturer from the Department of Periodontics, Vishnu Dental College. So patient named 24 years old patient came with a chief complaint of muscle tenderness in the lower right half of the face and also on the neck and right joint region since 1.5 years. And also he is complaining about frequent headaches as well as she is having a habit of night bruxism. This is the chief complaint of the patient. On examination, all the signs and symptoms of the occlusal disease are present, and also there is a mild pain on the right side condyle Along with that, there are painful masseter muscle and lateral pterygoid temporomandibular ligament spasm is also there. And there is a moderate wear on the lower anterior teeth and upper premolars and canines also. If you observe that there is a flat canines suggestive of night grinding habit, and also the mouth opening is normal. So if you see the MIP pictures, there is slight flattening of the canines as well as some pictures are looking good or something, any blur? No. So if you see the canines, there are flat canines on both the sides because of the patient is having night bruxism. So, and also there is no contact of the canine on the right side because there is a labial lingually placed canine on the right side. And also there is attrition on the lower anteriors. So patient pre-existing occlusal scheme, that is on the functional side right, there is a guidance of 1314, 1617, like groove function involving with interferences in the posterior aspect. And also on the non-functional side, there is an interference in the 14 and 16 region. And also in the functional side right, left, there are interferences, and also on the non-functional side left interference that is there on the 27. If you see the protrusive view, there are posterior protrusive interferences on 14 and 16. And on the left side 24 and 26. This is the pre-existing occlusal scheme of the patient. And to protect the patient privacy, I have taken all the records, but I am not posted here. So if you see the open and closed view of the condyles, the right side condyle, right and left side condyles are okay. There is no significant changes in the condyle glenoid fossa. But if you see the slope area on the left side, there is a flattening of the eminence, posterior slope of the eminence, and in the right side there is a steep eminence there, no problem. But if you see the position of the condyle on the left side, there is a slight anterior positioning of the condyle than the right side. So it is like patient is having contraction of the muscles on the right side. While moving in opening, the mandible is moving towards the right side. In the range of motion while opening, the mandible is moving freely, with left side is moving towards the before the eminence, but the right side condyle, it is little bit posterior to the left side condyle. It is correlating with my clinical examination, like right side patient had a muscle spasm with masseter and all the muscles. So because of that only, the range of motion is different on left side and right side. So I advise CBCT, but before that I have delivered single arch overlay deprogrammer for the patient. She is very much comfortable with the deprogrammer. So that is why I have started taking my records. So, and also I educated the patient regarding uses of night wear after the treatment also, because patient is having night bruxism. So that is why I motivated and educated the patient. After treatment also there is a requirement of the night guard. She agreed for that. So then I have taken all the records like impression, Facebook transfer. So Facebook transfer is also an important step, because the maxillary position in the face, that will be transferred from the face to the articulator. So that is why it is an important step. And also I have taken centric relation bite with following the principles of the deprogrammer, like it should be perpendicular to the long axis of the lower anteriors, and also there should be disclusion of minimal posterior disclusion. So followed everything and taken centric relation bite. After taking centric relation bite, so I have articulated upper with the face bow and lower with the centric relation bite. So my first point contact, important step, my first point contact coincided with the patient mouth in the articulator. So then I have started my treatment planning. The first point contact at 1.6 and 4.6. And at that CR level, my vertical pin reading is plus 1.5, and at MIP plus 0.5. The slide is 1 mm only. And it is towards the tongue. If you see the slopes, palatal incline of oblique ridge of 1.6 and outer buccal incline of lower 4.6. It is telling that palatal incline of upper and buccal incline of lower. So it is suggesting that PUBL rule. So mandible is shifting towards the tongue side. So right side mandible is shifting towards the tongue side. So okay, till now it is okay. So I have suggested ortho treatment for the patient, because there is a lingually placed canine in the lower right. And also patient age is 24 years. So that is why I have suggested ortho treatment, but she not agreed for the ortho treatment. So that is why I have opted for both restorative and additive reshaping. So, but it is possible to only equilibration or with the additive also. But some problem with the equilibration. If you go with the equilibration in this case, there is much amount of equilibration in the posterior aspect, posterior teeth. And also there is a need for the anterior equilibration also. For example, if you see the anterior teeth contacts after removal of the posterior segments, only out of 12 anterior teeth, only 4 teeth are touching. If you proceed with the equilibration, with 4 teeth touching in the anterior teeth, there is a requirement of anterior teeth equilibration as well as more amount of equilibration in the posterior teeth also. So to avoid much amount of reductive reshaping, I haven't planned only equilibration. And also additive also some sort of issue. For example, if you plan for any additive reshaping in this case, there will be more amount of composite addition in the anterior aspect. That is maybe not stable. If patient is not maintaining well or if patient having night bruxism, it is not possible to maintaining. So that is why I haven't opted for only equilibration and only addition. So some sort of equilibration and addition, both the tools I have used in this case. So in the anterior aspect, my vertical is 0. So my patient vertical is plus 0.5. So I have started my equilibration in the articulator. The plus, my CR first point contact at plus 1.5. So I have adjusted like 1646, 1415, 24. So till I have reached my patient vertical, that is plus 0.5. So from plus 1.5 to plus 0.5, I have reached through reductive reshaping. So after that, I have reached the patient vertical. Then I have, so till now, I have achieved contacts on the posterior teeth except all the 7s and 2.5 and 3.5. And also the anterior teeth. So I haven't achieved all the anterior teeth contacts and posteriorly 7s and 3.5 and 2.5. So I stopped at patient vertical. Then I have started additive reshaping. So this is the mind mapping for the patient. For example, if you see all the 7s only restoration, anteriors only restoration, and additive and reductive reshaping, both green and blue suggesting depict that both equilibration and restoration. So this is the mind mapping. So after my reductive reshaping, I have started wax up of the articulator. Then I have added wherever required, like mesial marginal ridge of the upper anteriors, like I have added. Then I have fine-tuned the wax up, because if you, after adding the wax up, for better chewing efficiency, we need to add the wax up and the slopes also. So that is why I have added. Then I have repeated in the same, in the lower also. Then I have checked for the dynamic contacts. So, so my anterior guidance occlusion on the right side, premolar and canine. On the left side, only canine. So I have, groove function, why I have given groove function occlusion on the right side? This canine, lower right canine, it is lingually placed. So that one teeth is not possible for the guidance. So that is why I have taken the guidance from premolar also. So that is, so anterior guidance occlusion with groove function involving the premolar on the right side, only canine guidance in the left side I have planned in the articulator. So after that, after wax up, I have checked in the articulator. So there is a groove function occlusion on the right side with canine and premolar, and left side only canine is guiding. On the non-functional side, as per the occlusion principles, there is no contacts required on the non-functional side. So there is no contact on the non-functional side, because in non-functional side, the condyle is moving towards forward, downward and medially. It is highly unstable position. So that is why there are no contacts required on the aspect. So no contacts on the non-functional side. And as well as in the protrusion, while protruding, only need of anterior contacts, there is no need of posterior teeth contacts. Because in this position also condyles are very unstable, because they are moving towards forward and downwards. So I have done in the articulator, then I have started in the patient mouth. with cois inside the mouth. After with adjusting, I have converted the cois reprogrammer into the equilibration plate. Then I have started my equilibration in the patient mouth, and that will be my first point contact. We have seen in the previous slides also. So after I have adjusted as per the equilibration sheet, but some changes like in the articulator and patient mouth, some little changes were happened while adjusting in the patient mouth also. So the problem happened in the second case also. So why, I don't know. So but majority of the dots I have issued like in the equilibration sheet. So then I have started my additive reshaping with Hexaclear mold. I have taken mold with the wax up and then started additive reshaping for lower teeth for all the required areas and for the upper also. I have done my additive reshaping, and then these are the static contacts. I have achieved all the mesial marginal ridge contacts on the anterior, wherever central fossa and palatal cusp strips for the upper and buccal cusp strips for the lower. So again, right latrusive. So canine and premolar is also guiding in the right side. On the left side, canine is guiding. There are no lines in the posterior. And right mediotrusive, no lines. Left mediotrusive, no lines, only dots. And protrusive, both the centers are guiding in protrusion. This is the excursion picture. So, and there is no requirement of the long centric in this patient. I have checked long centric adjustment, is it required in the patient or not. So both the dots are coinciding, so that is why I haven't done any long centric adjustment for the patient. So patient, I have recalled the patient after my additive reshaping after 3 days. Patient is very much comfortable with the mesial pains, very much comfortable. So I again recalled after 6 months. So these are the static contacts. Light latrusive, canine and premolar guiding, left latrusive, and excursions. So occlusal scheme. From pre-treatment to the post-treatment, in MIP, if you see the canines, they are flat in the pre-treatment. So I have added like something better than before on the right side and also on the left side. Open mouth, aesthetic view. Lower, I have added already restorations in the lower teeth, so they are looking good than before. And even though in the pre-treatment also there is a sufficient overjet and overbite is there, but canines are not contacting. So in this picture, post-treatment and 6 months, there is a good contact for upper and lower canines also. And functional side, the groove function is shifted to groove function without any interferences, but in this picture it is looking like there is no contact for the premolar. Actually in the range of motion I have taken at the last stage of the, so that is why it is looking like only canine guidance, but in the initial stages canine is also guiding. So and on non-functional side there is no contact, there is a change from pre-treatment to the post-treatment, there are no contacts on the non-functional side. And also functional side, there is a canine guidance on the functional side left. And non-functional, there are no contacts. And protrusion, both the centrals are guiding. On the left side also, there are no posterior teeth contacts on the protrusion. So I have advised DASA, I have delivered DASA for the patient. So because patient is having a night practicing habit, definitely there will be a need for the DASA. Before concluding, I would like to say about something like voice. It is Vishnu Occlusal Integrated Curriculum for Enhanced Learning. It is a curriculum we introduced for the students, all the undergraduate students in our college. So why we introduced this curriculum to the college? Because centric relation is an important step to learn for the students. Without understanding the centric relation, it is not possible to give proper occlusion as well as long-standing stability of the teeth as well as the condyles. So that is why we introduced centric relation based approach to the curriculum. So actually previously 24 faculty members from the college we have trained for the course. So this is the curriculum we introduced for the BDS students. So initially, in the first 2 years, we introduced only basic sciences related topics like muscle examination, TMJ examination and all. Later years, we make them acquainted with the clinical application also. So and also in the DADH lab, they are doing additive reshaping along with the reductive reshaping carvings. And also we introduced these occlusal concepts into their record books for their better understanding also. So students are doing face bows. These are the pictures of them only. Students are taking party impressions, face bow transfers. Now they are doing deprogrammers. Later in July, they will complete centric relation byte record also. And in our department, we are doing some kind of studies related to centric relation, various types of deprogrammers and their effect on the periodontal tissues. So these are all the studies we are doing. And not the least, along with those, we started a new department in our college that is called as Department of Occlusal Medicine. Okay. Thank you, thank you, sir. Thank you for everything, sir, for your support, guidance, encouragement. So without this course, I'm not able to do. So right now we are doing condylography in our college also, sir. So without these concepts, I'm not able to understand the condylography also. Yes, sir, definitely. Without this knowledge, I am not able to understand the condylography, sir. So thank to all of you, sir, all of you. Thank you so much, sir.
Thank you. So the best part is we always feel like whenever we travel there, no, it's not easy every month. Sometimes initially whenever sir is here, sir, ma'am came once and they'll come. In between we had very tough time when we travel to the college. Every visit will be a nightmare for us because my younger son was very young. He has to see the face of Malar while sleeping. So that's the situation. Ma'am has seen that live. Many a times we had very, very tough situation. She has to open the camera in the train. In the train we'll do the sketches. So there's a lot of hard work there. So as a team, as sir, and we have done very a lot of hard work there. We invested, but when we see this, like sir said, seeing him crying is not usual scene which you will see. Okay, so he's very practical man, not like us. Okay, so thank you. Say convey our special regards to Anand sir because this is phenomenal. Okay, if the college is going to do all this, why we should run a course? I always feel after BDS they should know everything, right? 5 years they are learning, then for the 3 years they are learning. They should learn all this there itself. Why there is a course? Why there is a fees? Why there is a mentor after that? Let them learn advanced things they can learn. Thank you, Venkat Lakshmi, and thank you, Vishnu Dental College, for this. This is something phenomenal. Thank you. Yes? Still you want me to convey? Okay. Okay, great. So we have, can you all get up? We didn't do anything from morning here. Can you do some occlusion claps here? You are in my control till you get the certificate. After that, I can't say all this. Naturally, you will make me stand. This is not occlusion claps. No, you know what is occlusion claps. Ready? 1, 2, 3. Hey, NCC camp adu. I just need 3 taps. Okay? Ready? 1, 2, 3. Oh. This is crossover interference. After all the guidance is over, still the interference. Ready? 1, 2, 3, please. Ready? 1, 2, 3. Ready? 1, 2, 3. Ready? 1, 2, 3. Hope everybody woke up, right? So I'm happy for that. Please sit. Something will tell me, hey, make them get up, run there, see their face, give them water. All these are intuitions. Okay. That college is a very, very nice college. If you find time, please go and visit their college. I had the privilege to learn condylography there with Dr. Divakar Singh. He is a pioneer. He is a pioneer in condylography. But rightly she said, no, condylography will mean nothing if she doesn't know the basic things what we have curated as a curriculum in ODD. Bhimavaram, Andhra, Vishnu Dental College. There are sterilization protocols. Think about it, no. Thinking about occlusal medicine. Last time I went for condylography, they took me and Muller and we saw every department as an occlusion trolley. Every department, almost like they took a few departments, they have an occlusion trolley where they have articulating papers, photographs, 40 micron brush, blue, red, cut, everything ready, what is needed for occlusal mapping, everything is ready on the trolley. So they have to 100% follow. The students doesn't even know what they are learning is a very, very premium thing, right? So it's like a basic thing they are covering. So they took me to the lab, additive lab. Who is teaching additive, no? Why do you want to, I always ask, I always wonder why we are carving the root of a lateral incisor. Why are you going to carve? Have you extracted and carved anything? Then what is the point in doing a carving on a root, right? So it's more of additive work we do. So in the lab, I was stunned to see, they took me to the lab. In the lab, they have the sketches. Whatever we have given, that sketches are there with them. They learn the anatomy. They'll add everything according to the anatomy. They have 3D printed things which the students have to do, do the additive work. Think about the quality of education they're going to get there. Okay, seriously, I want to do BDS again. That is what I felt when I went to their college. That college itself is like that. It's so homely, so nice, phenomenal. But great colleges, everybody knows Savita. But still we have a question, where is Vishnu Dental College? You understand the difference, no? So that is the power of, what to say, social media. Okay? Okay.